third limb, is there a non-viable twin? Sometimes these twins are not all in the same health condition. If there is a twin that's actually causing danger to the other twin from anomalies, from problems like that, and we do not anticipate him to survive, then we can actually, let's say, cheat towards the more favorable twin, or the twin that will likely to survive. If none of these options is there, then we ask ourselves, is there tissue that we can borrow? No, then we ask ourselves, can we do an osteotomy that will actually make the gap smaller? And that happens quite frequently with the Esciopagus quadrupus, where they have 4 limbs. After the separation, you can see a huge gap between the in the pelvis. I'm sure Dr. Jawadi will explain to us their wonderful interlocking osteotomy that allows us to actually bring this gap together, and from that huge thing, we can come and close this. If we don't have any of these options, then we ask ourselves, what are we missing? Are we missing skin only, or are we missing also structural integrity? And what do I mean by structural integrity? It's fascia. Like I said, it's very important. We have to cover the viscera with fascia and muscle. Sometimes there's bone, like in the skull. So these two are the structural issues. If there is no structural deficiency and we can close the fascia, all what we are missing is skin, then the answer is very simple. It is basically tissue expanders. We do a procedure before that. We put tissue expanders in the kids, inflate them over time, and then when it comes to separation, use the extra skin. If there's a structural deficiency, such as in craniopagus children, we need to do reconstruction. We need to reconstruct that structural deficiency. So there is a first stage, which is tissue expanders that will give us the skin availability. But then at the time of the separation, we have to use some allograft material, such as dural patch, like you can see here, to cover the brain, and then we use the tissue. So, and then once we finish with all of that, finish our reconstruction, we go into our dressing, and that's again by the plastic surgeon. Again, we try to keep it simple. I'd like to take this opportunity to talk about our craniopagus separation experience at the King Abdulaziz Medical City. I was privileged to be involved in 3 of them, and I heard there was a 4th one is done since I left. That, to my knowledge, represents about 6% of the total craniopagus surgeries that were done worldwide. Preoperatively, our investigations, we do everything. Again, like I said, and we do 3D modeling, and we do virtual surgery, and we try to figure out every little minutia. Here, if we follow our diagram before, we do have deficiency in the skin, and we do have structural deficiency. And the structural deficiency is dura, so we need to do dura graft as separation, and bone, so we need to do bone grafting after the patient has recovered from the separation. And with the skin problem, we need to use tissue expansions of the scalp prior to the separation. So I go through that. There are meetings, discussion. Plan is multi-stage operation. Now, this thing I want you to understand. The 2 kids are stuck at the head, and the vasculature and the tissue of the brain is connected to each other. So the neurosurgeons have to separate these 2 parts, the brain, apart. They have to separate the dura, the brain matter, and the arteries and veins. It is done in quarters. If you imagine it's a pizza, it's done segmentally. Either they do it at 3 stages to go all around, or they do it at 4 stages. The decision is up to them. Every time we go in, they separate a stage, and then they put something that prevents revascularization, reconnection between the 2 segments that they freed. That's usually silicone that they place. So first we determine our separation line, like the usual kids, and this incision is going to be used by the neurosurgeons to go every time to the brain and try to separate a segment of it. And we have to use that same incision to put our tissue expanders at a later stage. So they go in, they do their craniotomy, the bone flap is saved, they bring their microscopes, they start separation. Now, why do they do it segmentally and not one go? Because we have learned from experience, not our experience luckily, experience previously from other centers, that sometimes one twin is dependent on the vasculature from the other or on the venous drainage from the other. So if you suddenly cut off the connection, there might be either ischemia or increased intracranial pressure. And so doing this at segments allows the patients to actually, allows the brain to revascularize, and you are introducing the change sequentially. Once they've done part of it, they put dura, they replace the bone, and close again. We come a second time, you do this, the other third or the other fourth, and then at one stage, when they're only left with one segment to separate, we come in and we put our tissue expanders. Because the final part that will be separated at the final procedure. And we need soft tissue, we need skin to cover the brain. So sometimes we put 2, sometimes we put 3 tissue expanders. They are put under the galea, and they are placed in a way that there is no pressure on them all the time, because sometimes we can get tissue necrosis through the tissue expander. We try to inflate them very slowly. They are expanded over time until adequate skin flap is achieved. We come to the final separation. We remove the tissue expander. We start doing our flap that will be covered. It will be divided between the 2 patients, and that gives ample area for the neurosurgeons to actually do their craniotomy and open the brain. They come and do the same procedure that they were doing sequentially, but this time we end up with 2 separate patients. Once that is done, again, we separate the patients into 2 tables like the others, and we start our reconstruction. As you can see here, we use the native dura as much as possible, but we are left with a defect, and a dural patch was applied, and here we can utilize our expanded flap to cover the brain. This is closed, patients go to the ICU, and they are separated. However, we did not complete our structural reconstruction. Remember, there is bone problem missing here. We cannot do the bone at the same time if we are not sure of our skin coverage, because if you place bone and the skin coverage breaks, then you'll have a problem. Sometimes, of course, if the children are older, you can use split calvarial bone graft, use their own bone, but most of all the ones that we did were young. They come now as normal patients with a skull defect. One by one, as you can see, there is a marking on the rib. We do it on both sides. We harvest alternate ribs, close the defect, split the rib, gives us extra, reopen our flap, see the defect over the dura, find the edges of the native skull, put our ribs, fixate them, use bone source, calcium hydroxyapatite, and osteoinductive material that hopefully the bone will grow through, close the patients. And I had the chance to see the Omani twins in this conference, the picture down here. Thank you very much, and welcome to Saudi Arabia.
Thank you very much. Our third speaker is a pediatric general surgery consultant from the King Abdullah Specialized Children's Hospital of the Ministry of National Guard Health Affairs, Dr. Saud Al-Jadan, to speak about hepatobiliary and gut anomalies patterns in conjoined twins. My bad. Challenges in reconstruction and wound coverage, Dr. Abdullah Altanayan, the head of plastic surgery from the Specialized Medical Center in Riyadh. Dr. Altanayan.
Assalamu alaikum. Good morning, everybody. I would like to thank the Scientific Organizing Committee for this great meeting. And I would like to start my presentation. Actually, it's a complete of what Dr. Azzawi mentions and the challenges in reconstruction in conjoined twins. As everybody, when it presented, it's a multidisciplinary team. I will not go through this. And all the labs and radiological studies needed will be done. And the timing of the surgery, when the patient's condition allowed us, we will fix it. And then after a multidisciplinary team decision is it one go or we have to do tissue expanders before as a staged operation. Types of conjoined twins, I will not go through all of them, but the things that need plastic surgery, sharing the separation, the craniovagus, in terms of tissue expanders, and thoracoomphalovagus in terms of tissue expanders again, and the biovagus, the intraop reconstruction is one stage, and the thoracoomphaloischiovagus, whether it's tetrabus or tribus. The craniovagus, as Dr. Azzawi mentions, it's constituted around 10% of all conjoined twins. And usually the limitation for surgery, as he mentions, not enough soft tissue coverage, very thin skin to expand, and you can see the port, and you can see also the very thin skin under the tissue expander. The post-operative complication, as he mentioned, we don't want the dura to be exposed and the metals also. The thoracoomphalovagus is around 40 to 50% of all conjoined twins. Limitation of surgery the same, not enough soft tissue coverage. Preoperative diagnosis, usually we do it stage by tissue expander. There is intra-op tips. Even sometimes when we close the skin, the xiphoid process is so prominent that we have to trim it, and we have to put some wires or proline stitches to bring it down so the soft tissue will be easily come. We did separation component of the recti muscle to bring it, as he mentioned, the fascia and the muscle has to close the bowel. And then the skin, we close it. And sometimes we cannot close the skin, and we use the vac machine. And this was around 2004, and we were the first people using the vac machine because we don't have enough soft tissue to cover. We don't know what is the complication of the vac machine in pediatric, because that one time it was in the era of the tissue expander using only for adults, not for pediatric at the age of 1 year. But we manage with the vac machine, bring the soft tissue together, and the small area after the good granulation, we put skin graft. The post-operative diagnosis at the same time, we think that it's not, we close it with non-tension suture. I need the screen here. We close it with the, can we get slide back?
The monitors are not working.
In the biovagus, we treat it like myelomeningocele. Usually, we release the skin in the flanks, and we close the midline, and we use split thickness skin graft in the side. In thoracomphaloscuopegus, usually we fracture the hip, and this will be mentioned by our friend Dr. Jawadi, and then we close the midline. Usually it's not a major issue. The tetrapegus is much easier than tribus. The thoracomphaloscuopegus tetrabus, this is the most challenging reconstruction because the principle we're using the surgical reconstruction by filleting the shared leg. And after we check the third leg, the most important thing is the blood supply of the shared leg. And it's very difficult by using slow phase and rapid phase of CT angio because of the venous plexus in the pelvis. We cannot tell which blood vessels will go and where is the area of the separation when it comes to the limb. And also not only the blood supply, but also the orientation of the skin towards covering the third buttocks, whether this will be kinked to the blood vessels or no. Though the shared leg, when you pinch the baby in the front of the leg, usually twins A will cry. And when you pinch the baby posteriorly, twins B will cry. So the nerve is separated, the sensory nerve is separated and will demarcated between twin A and twin B. But we cannot be sure that the blood supply is carrying the same principles, that the blood supply will follow the nerves. In the earlier cases, we used in one case a Gore-Tex sheet because this is a stage operation. We don't know the blood supply. We cannot identify which shared leg will have the blood supply from which. So we didn't remove the bone. We separated the soft tissue from both sides, and we put a Gore-Tex sheet to prevent vascularization from each side. And after 3 weeks, we separated at the end. But during the intra-op of this case, we don't find that the Gore-Tex sheet did a lot of things for us that we need to use it as a model. So we went back to single-stage filleting in later cases. This is the cases where we demarcate the mid-lateral and mid-medial, and we remove all the bones from the femur, tibia, fibula, and also the tarsal bones. Doesn't go with me. This is the first one. The second one also, this is the tribus. So after we separation the shared limb, it's a huge defect. We have to mobilize the muscle of the external oblique, part of the rectus to cover them. And we managed to cover, though after post-operatively the tension was a little bit tight, so we have to release some sutures and we apply a vac machine. This is also after filleting down to the toes, orientation of the flap, and we oriented which the best way to close, and then a closure of the defect using the shared limb after removal all the bones. Now, in the future, as done in the craniopagus, detailed 3D printing is very important to see in the future, though it's very expensive, but it's needed. And detailed classification for each type, like all the tribus patients, the maturity of the shared leg is different from each other. Sometimes they have duplicated feet. Some of them, they have 1 foot. Some of them, they have like a mirror foot. And more classification will make this easier to plan the separation. Thank you very much.
Thank you, Dr. Abdullah Thnayan, who's a senior plastic surgeon, a member of our conjoined twin separation at National Guard. It's a pleasure to present a dear colleague, Dr. Saud Al-Jadaan, who's a senior pediatric surgeon, did his fellowship in Ottawa. He has 26 years experience with conjoined twin, and he's going to talk about hepatobiliary and gut anomalies pattern in conjoined twin.
Assalamu alaikum. Sabah al-khair. Good morning, everybody. We will talk this morning about hepatobiliary and gut anomalies patterns in conjoined twins. I will not go through the details of history and classifications being covered by many speakers yesterday and today. The only thing that I would go through is the types of conjoined twins. And for the commonest type, which is the thoracomphalophagus, it depends where you read it, whether they include the separated twins or only all the deliveries. So it ranges between 56 to 73%. The majority of anomalies are cardiac. Gastrointestinal anomalies, as was reported by Wallaby in one of his papers, was 17%. I know that they talked about the first documented successful separation of conjoined twins was mentioned before, but I found this picture to show the communication is only with skin and no internal organs. It was performed by Dr. Johannes Fatio in 1689, and there is a tragic end for this surgeon. Unfortunately, he was executed. I read about him. It was at a younger age. This was done in Basel, Switzerland. If we go out to our statistics, the majority of our patients are Saudis. We reviewed, now I think we reached 61 cases, but we reviewed for this presentation 60 conjoined twins. This paper was published before about the hepatobiliary anomalies that we encounter. There are a total of complete separation of biliary system. We had a total of 16 cases. 7 cases were isolated liver and biliary anomalies, and the rest are with GI anomalies. Pattern 2, I'll show you pictures of those. They were joined common hepatic duct and single common bile duct and ampulla. Pattern 3, which is completely separated system with a shared ampulla. And we have 2 cases of shared complex hepatobiliary and pancreatic system. So out of our patients, we had 40% with congenital anomalies compared to Wallaby's 17% in his series. This is pattern 1, where you see the completely separated biliary system, only joined by liver tissue. This is pattern 2, which was joined common hepatic duct with single common bile duct and ampulla. We had 3 cases. And pattern 3 with completely separated system with shared ampulla, we had 3 cases. And this is the more complex pattern, which is pattern 4 with shared complex hepatobiliary and pancreatic system. We had it in 2 cases. This is set 12, which is number 12 in the twins reviewed. This is a more detailed picture of the same pattern. For bowel, we are proposing this classification where pattern 1 is isolated shared duodenum. We had 2 cases. For pattern 2, they have shared duodenum and jejunum. We have 3 cases. And pattern 3A, where they have shared ileum, colon without anorectal malformation, 1 case. And the most common is pattern 3B, where they share terminal ileum, colon with anorectal malformation. We had 15 cases. And pattern 4B, where they have shared distal colon without anorectal malformation. We had 1 case. We had 2 separate anal openings. And 4B, where they have shared distal colon with anorectal malformation. We had 4 cases, so we had a total of 26 cases. This is a contrast study. You can see the dye is coming, it's being given to one twin going into the stomach. There is a shared duodenum, and you can see the beginning of the stomach retrograde on the other twin, and you can see the gastric bubble. This twin, they have contrast study given to both babies, and they have a joined small bowel. This is a contrast enema, and you can see on the right there is a shared colon, and you can see on the left the beginning of the small bowel. I can see 2 separate small bowel in both, each belonging to one twin. And this is 2 twins. You can see the shared rectum, and then large bowel and small bowel are separated with a single anal opening. So to summarize it, we had 60 sets of conjoined twins that we reviewed, 34 cases with intestinal, colonic, and hepatobiliary anomalies. Hepatobiliary and bowel involved in 16 cases, isolated hepatobiliary involvement in 8 cases, and isolated bowel involvement in 10 cases. Common finding also, there is usually Meckel's diverticulum in those babies when we operate. Here you can see that usually with the colon there is a dual blood supply. So to separate them, it's a matter of which one gets what. But the blood supply usually is not an issue for when we separate those twins. And here you can see the terminal ileum is being joined, and then eventually it will go to the colon that is shared between the 2 babies. This is another picture of duplicated blood supply to the colon, which makes it easy to separate. And this is where they have shared duodenum. We need to look sometimes for the ampulla, and sometimes we have intraoperatively to do a retrograde contrast study through the ampulla to identify the biliary system. We had 2 cases where they have cloacal exstrophy. This is one set of cloacal exstrophy. And this is a closer photo. You can see some bowel also coming with bladder exstrophy. And this is after they had colostomies, diverting colostomies. And this is the final stage of bowel separation prior to separating the 2 twins. And this is another picture of the 2 bowels being separated for 2 things. For the complex cases with anorectal malformation, we have a team of anorectal service in our hospital. And before we do the separation and what to follow, we always discuss these in details and then plan for the reconstruction in the future. Thank you very much.
Our last speaker for the session is Dr. Daniel Coros. He's a clinical associate professor from the University of Alberta in Canada to speak about dealing with conjoined twins in the ICU. Dr. Coros.
Thank you for this opportunity of being here. I want to thank the organizers, Assalamu alaikum, and thank you very much for the hospitality that has been wonderful for me here, first time in Saudi Arabia. And for me, it's a pleasure to be here, not only because of the KS Relief Center beautiful work to witness what you guys are doing, but also because I have a connection with Dr. Al-Rabia. He was trained in my center in the late 80s in the University of Alberta Hospital, now Stollery Children's Hospital of Alberta. So, Dr. Al-Rabia, I feel honored to be here in the same place and see the work that your team is doing with this unfortunate population of twins that you are now giving hope and dignity in making them citizens of the world. This is amazing work, and I'm so happy to be here being part of this conference. Thank you. So for me, I have a great connection their way, and the connection continues because we have now Dr. Mohammed Al-Ubailan with us, a wonderful fellow working with us in the pediatric ICU and the pediatric cardiac ICU. And here is our center in the middle of Canada. We are a regional center for the western provinces of Canada, where we drain all patients to our center for heart surgery, many types of transplants, and except for BC Children's Hospital, they have their own. The rest of the centers that I listed here all send patients to our center for ECMO and for ventricular-assisted device and all the technology that we can offer in our PICU and pediatric cardiac ICU. So my experience comes from this work that we do in terms of quality and preparation for surgical cases, and these are the connections between our two cities, Edmonton and Riyadh. I will focus, because I only have 20 minutes, I didn't know where to focus my talk, so I'll focus on three aspects. One is, are we ready for the patients that come to us in terms of quality work and safe work for these children? Are we ready for the ethical issues that we face? And are we ready to deal with impact on our team when things don't go well, when things don't go the way that we think that they should go? So is the PICU ready? This is my center, my PICU, as we inaugurated a few years ago. So the first thing is already mentioned many times is the fact that this is a team endeavor. And I just highlight the fact that the PICU must be present in every meeting, in every consultation, even nowadays with telemedicine from other countries, and we do telemedicine throughout our western provinces for all the surgical cases that are referred to us before the patients come. But it's important to include the learners, residents, and fellows, and also super important, include the palliative care team and the ethics on these occasions. So the immediate post-operative period has been compared to a pit stop of a Formula One car in many situations. So the care transfer requires effective communication. And it's important here that we take principles of Formula One and aviation, and is the crew management and the situation awareness concepts. And the roles need to be well defined. I want to tell you something very practical. Nurses, for example, one nurse has to just listen to the transfer of information and take notes. The others do the line checks, the positioning, the monitor adjustments. It's important also to bring the patients to the ICU with the same drug concentrations that are used in the operating room to avoid confusion, avoid hypotension, and wrong medications. The report has to be done for the two patients in separate areas with the two teams, and the anesthesia speaking, and after the surgeon speaks, they have to be specific to the points that are needed for the ICU to function. And at the end, we have to do the feedback loop of communication. We intensivists need to feed back and see. So, for example, this is Hussein Twain A. This patient received this type of repairs. This was what we understood, and these are the recommendations, correct? Correct. So it's very important. And it's impossible to be clear on all of this without having protocols or a checklist. This is our checklist. If there's a direct handover, in this case, it's always a direct handover as opposed to an indirect handover. And these are the things on the right column that each of the groups need to follow. Prior to reports, the first phone call from the operating room, then the surgical report, all those items need to be reported, anesthesia report, and then the intensive care role, clarify and complete the post-op report and ensure that we review the orders. And we have a QR code at the end. If we detect that one of the anesthesia people or one of the lovely surgeons that we heard here misbehave, we report them on the QR code. No, just kidding. We actually make a note and say, what can we improve next time? Right there and then. So it's very well rehearsed and trained. So this has been shown, this kind of protocol, to decrease errors. And this is a paper from Montreal, and they gave score values for the information given. And after starting a protocol, there was a significant improvement in the score value, meaning less errors in communication, less errors to the patient. This is also being described in Chicago. Transferring patients, errors came down from 6.5 down to 2, and the verbal omissions were dropped. And the methods of communication, you can pick and choose, but you can use methods that are well described in the literature as the IPASS or S-bar. Those are methods that we use. I had a little video. Oh, there you go. So despite of good training, sometimes things don't go well, as you can see, even in Formula One. So the errors are important for us to mitigate and decrease. And protocols and checklists exist for that, to help with our poor memories. So the day-to-day in the ICU, it's important for us to decrease morbidity. You guys do such a wonderful job preparing these patients, operating on them, 12, 15 hours of surgery, and then the ICU goes there and make something bad, and the patient does poorly. That's not good, right? So we have to work together and use techniques of quality and safety to maintain these patients not just alive, but decrease morbidity. And some of them, more importantly, are related to infections, right? So we are part of solutions for patient safety in our hospital, and this effort already has saved a number of children that you can see there, with an estimated savings of $613 million since 2012. And this program is about decreasing unplanned extubation rate, surgical infection rates, and decreased catheter-associated urinary tract infection. And we participate in this program with all sorts of initiatives, as you can see on this list, that I don't have the time to describe to you, but we participate and we work with focus groups in each of these areas to improve patient outcome, to improve the outcome in terms of morbidity, not just mortality. One example of the initiative is the surgical site infection prevention bundle. So you do things pre-operatively, like the antibiotic exactly 1 hour, within an hour before, the chlorhexidine bath the night before, and another one just an hour before the surgery, and then intraoperative, the issue of changing gloves in different parts of the surgery to decrease the risk of contamination. And the post-operatively, we tend to control the glycemia and use of prophylactic antibiotics only for 3 doses, no more than 3 doses, not to induce resistance. All of these things, and using the checklist. And we also use a report and learning system. So if we detect anomalies, we can avoid doing it again by reporting the missed opportunities or something that went wrong that we can actually fix next time. The other important thing that we do is a huddle in the morning. So you see all the team around the table, including management, and we have all the information sharing. Who is coming? What kind of patient is coming? How is the ICU for that day? How many beds we have available? How many beds we need for transferring patients out to allow the two patients from surgery to come in. And we do have a code team there too. But it's important on the huddle that we actually do ask the question, who is the sickest patient in the unit right now? And then we go to that bedside and we rehearse the worst case scenario for that patient for 10 minutes. And then with that, we are prepared to, if something happens, everybody knows their role and everybody knows what to do. So that's what we call the huddle time. And we do twice a day in the morning round before for 10 minutes, 15 minutes, and then in the evening rounds, we do the same. So daily questions that can save lives. If you want to take something from this talk, take this slide here. So we do this in every patient every day. And we ask these questions. Can we extubate this patient today if the patient is not extubated? Is the head of the bed elevated at 30 to 45 degrees to avoid aspiration pneumonia? Is the ventilator circle downwards? And this ventilator circle, as you see, is not downwards. There's collecting water there, and that will bring pseudomonas to the patient. So the ventilator circle always has to be down. Are we on a closed suction system? And then we also use that routine. What else? Is the central line still needed? Can we remove the urinary catheter? Does the patient have a new fever? Does the patient have any pressure injury? Are we mobilizing the patient every 2 hours? So these are questions that save lives. And this is what we are all about: decrease mortality and decrease morbidity. So the family is very engaged. I don't have the time to go through all of this, but it's been shown that engagement of families improves safety and improve quality of care. They participate in our rounds. We invite them to come. They are there, even though that sometimes they don't understand everything. We will explain to them after. We tell them, we come back in the afternoon. And the nurse right away explains to them what we are talking if the language is too heavy for them. They help us to train our fellows and residents. I invite families to come back and do simulations with real families with the fellows. Taking part of the hospital committees, they help to design our facilities. They stay 24 hours with the patient, and they also answer a survey at the end of the day. Second question, are we ready for the ethical challenges in PICU? So, this is a quote from this twins that was the twins that lived the most recently in recent history. They just passed away earlier this year in the US. And one of the questions that they ask is, why fix what is not broken? The Chappelle twins said that. So it is an ethical challenge sometimes to think about we're making decisions for people. Obviously, they were used to what they live with, and they had that question in mind. But we have to think about some ethical questions about this. And the other side of the coin is this family of the Twister twins in London that were operated there. A mom said, I believe I was chosen to have Assam and Hussein. They were a precious gift sent to us. The world is a much better place with them in it. So, and they decide to separate despite the risks, right? So, two sides of the coin. So it's important that this paper in New England Journal of Medicine talking about the cases in a case in London describe all the ethical principles and questions that we have in these cases, so I don't have the time to go through. But I just want to highlight two things. One is dignity. So dignity is a very important ethical principle and has been talked about here. These patients deserve respect and dignity. And the other issue is, the other principle in ethics is the principle of proportionality. The proportion to what we do to them needs to be balanced against the benefit that comes from that surgery, that approach that we do. So the principle of proportionality is very important. So sometimes we have moral uncertainty. Ethical issues are there, we don't know what to do. So that's moral uncertainty. We have moral dilemma when it's a situation that two things can be done by one person says this needs to be operated, the other person says no, this kid should not be operated, and the outcome could be completely different, but both actions are ethically sound, morally sound, so there's no problem. That's a moral dilemma. More than one answer is morally defensive, but none leads to an ideal outcome. And then you have the third thing, which is moral distress. A clinician knows what to do, but he cannot do it because there's something blocking that action, either at the personal level, at the coworker's attitude, the conflict with teams, institutional obstacles, even circumstances beyond our control, which is common for conjoined twins living in a country without any resources. And the moral distress, the action that we think is the correct one to do is blocked. So, is the PICU ready for the aftermath when things go wrong, right? So, moral distress then is this painful feeling or psychological disequilibrium that occurs in situations in which the ethically right course of action is no, but it cannot be done. So we are frustrated, we're angry, we are guilty, we have physical symptoms, that's why it's called the embodied response, we don't sleep well, and we perceive that is affecting our moral integrity. So this is called moral distress. I know what to do, but I can't. And this can happen in situations of conjoined twins.
I don't know how you handle this.
Their child just died. You expect some reaction.
We're lucky. We get to walk away. We don't have to be there all the time. You're making arrangements. You're helping with the family.
But you're part of the team.
Until I question a decision or I believe in something different.
You're still part of the team. Sometimes I even fight for something I don't believe in. I see that as part of my job, to make the family's views known at these teams' meetings. Advocacy.
How can you do that when it really goes against what you feel is right?
Who's this about? That kid, that family, that community, they're the ones that have to live with what we do.
We all have to live with what we do.
We all have to live with what we do. This is a film that we created for my group's research on moral distress. It's called Just Keep Breathing. So moral distress comes when we cannot do what we know is best. It's a healthy sign though. It's not a pathologic one. We are humans. It's part of being human to have the moral distress. We know what's the right thing to do, but sometimes we cannot do it, but we must go on. And this was very common during COVID, right? Very much indeed. So we know what we have to do, but we can't. So what comes out of this? Some triggers of moral distress quickly. Over-aggressive treatment with patients who are dying when you continue doing things that we shouldn't do. Care compromise due to lack of resources and administrative support, like work environment is not very good. Communication breakdown, conflict with families, the different goals of therapy, multidisciplinary conflicts. One here that we hear a lot is our voice is not heard. We don't agree with this, our voice is not heard. And the other one is there's no correlation actually with resilience scores. You can be resilient, but you can still have moral distress, and the problems are at the organization level more than yourself. So we have done a lot of studies on this and causes moral injury, and we call it burnout, but in many cases it's actually called moral injury. And what it is the situation of a consequence of moral distress. It's a broken system. It's not us being at fault. Erosion of our framework, and we are now having to decide who will live and who will die in conjoined twins, and this is a situation that can deal with, hurt our soul. So sometimes a deep soul wound that presses a person's identity, sense of morality, and relationship to the society. So this can go, one case can lead to another, and we can actually, if we don't resolve it, it can accumulate, and we can actually be in trouble for the rest of our lives. As some people come to me and say, "Doctor, I remember that case 25 years ago that I had." So it's a healthy sign, but we need to resolve it. So how to address? To finish off, there are some institutional measures that we can do. We have to overcome a culture of silence, and I know that you have a team that works together very well. So we are expected to raise questions and concerns. And we have dialogue. I always say we have an open door policy. And we do debriefing sessions, diffuse sessions, formal and informal, to allow us to discuss this with the staff. We do town halls. When we see there's a lot of gossip in the lounge, so we organize a town hall, the surgeons come in and they say, this is what we are planning on doing, these are the things that we think is the right thing to do, but we're open to hear questions, hear concerns if you think differently. Just by doing that, many people say, now I feel better because my voice is heard, right? So this is things that were organized, and mentoring and having sessions, ethical sessions. In many of the research that we have done, they say those are very useful. There are no seats left, the room is full. And at the organization level, lots of things that we can do, but I want to highlight this chronic patient rounds. Every patient that is in the unit more than 12 days, we have one meeting per week. All the staff, intensivists involved, and the social worker, the people from administration, and we discuss this as a group. And every decision that is made is carry on. And we don't go to the emotion of every doctor that comes in changes everything. That makes the nurses frustrated, makes the families frustrated. So we decide in these meetings what is going to be done, and we vote on it, and that's going to be done. It can be changed, but again, it will be a vote between everybody. So this is a very important tool, and I'll suggest that to have in your service. And at the personal level, I think it's very important to receive this every day. How are you doing today from your leaders? This is so important to be valued. Presence of the family, as I said, is very important. Decrease anxiety, depression, and even presence of the family allow us to have a less moral distress. And actually has been shown in this study in France that if a family is centered, there's less burnout, less moral distress, and less absenteeism. At the personal approach, I would say this: there's lots of ways to coping with stress. One thing is you should plug out of, like you do for your computer. When the computer doesn't work, you unplug and plug again. Do that yourself. Unplug yourself. The other thing is look at the mirror, check in yourself every morning with empathy, compassion, and say to yourself, I am feeling bad about this. I don't like it. But what do I do about it? I will call an ethicist and see if I'm doing anything wrong, but I will create a narrative that brings meaning to me. So during the COVID-19, 36% of people on this research in France showed that they were proud to be working really hard, and they are proud because they felt that they were growing on their own lives by being part of this pandemic, this difficult thing. The other thing that is important is to refocus, knowing that suffering in the world will always exist. You cannot change that. We can advocate like the chaos relief is doing, you can do the job, but we have to recognize that we cannot change circumstances that are beyond our own control. So what we do then? We fight for what we can control. And what we do, we are effective. We are the best physicians, the best nurses that we can be, and we are doing our best despite all the circumstances. So this is the way we can refocus. And the Japanese word kintsugi really works well here. When a broken vessel is repaired with cement and gold. And those vessels, when they are repaired with cement and gold, they get stronger. And that principle is the principle existential hardness. A person that is resilient is competent, has some spiritual influence, is easy to accept changes, can control him or herself, and has secure relationships. These are so important because this way we can handle the difficult situation that we face. I love this quote from Dr. Cinda Rushton that says, we choose how to respond to our ethical challenges, our dilemmas, the uncertainty, in a ways that it brings us integrity, preserves our integrity, it minimizes our own suffering, and allow us to serve with the highest purpose. And everyone here working for these conjoined twins has a purpose, a very high purpose that is beyond just good papers published, correct? And this is what leads to our moral resistance. Don't forget that talk to your team. Peer support increase our resilience by 7 times and work engagement 5 times. And we can actually do several things during our peer support. I don't have the time to go through it.
Professor,
but
I think 1 minute left.
Yes, remember that you'll have a very successful program. Can we do even better? We can do better to be prepared for each child the best way. The protocols, role play, simulations, quality safety measures. Be prepared to face the ethical challenges, but be prepared when things don't go well. Resolve your own moral distress with good communication, open mind, allowing families to be participants in the care, and allowing the team members to find meaning on their work. Your work here is to give hope to families with a devastating diagnosis, and you have done it. Keep on doing. Thank you very much. Sorry for going beyond the time.
Thank you very much for the wonderful presentation presented by my colleague. And we're 5 minutes over time, so we'll try to limit the questions. An important announcement, the next session at 10:40 will be at the next hall at the exhibit room, okay? So this hall will be occupied. So we'll start with any questions. Dr. Tariq, can we have any microphone, please, for Dr. Tariq? Tariq, to speak up. I'll repeat your question.
Okay, Assalamu alaikum. Thank you for the great panel. My name is Tariq Al-Jared. I'm a pediatric neurosurgery consultant. I have a comment regarding our colleagues from plastic surgery in the craniopagus twins. I was part of the last 3 cases of craniopagus twins. It's very important to communicate with the plastic team before the operation about CSF collection and CSF leak. Many of those patients has difficulty to get a watertight closure or at risk of developing hydrocephalus after the operation. So if we don't deal with the cerebrospinal fluid collection, whatever reconstruction you guys do can be damaged by the presence of cerebrospinal fluid, either by leak or wound dehiscence. So many times we get involved about how to deal with CSF diversion, whether it's lumbar drain or during the planning of the incision, whether this patient is predicted to have a ventriculoperitoneal shunt, so that there will be no hardware underneath the incision line. And I think you guys had this experience in multiple of the previous cases. Thank you.
Thank you, Dr. Tariq, for your comment. Any questions? Any other questions? Professor Gattan?
Assalamu alaikum. I have 3 questions. One for the very nice anesthesia consideration paper. I always wondered why in big centers where they have a referral center for Siamese twin separation, why don't we have one big special set OR that's always there, huge, 3 anesthesia sets, 2 when they are together, and 1 when they separate, tables, everything. This is not waste of resources, because this OR can be used for other cases, but when the Siamese comes, it is preset. This is well known and is done for hand transplant centers in the US, and now establishing a hand transplant center in Saudi Arabia at King Faisal. and we're preparing this kind of OR. This OR is for Siamese. Everything sit there. It also includes special suction and special temperature control. In addition, you know, our neuro colleagues need this MRI in the OR, you know, to check. So everything will be in that OR. Does this actually exist in your center?
No, this doesn't exist. Well, actually, I take that back. Where I work currently, there is one room that can easily accommodate 2 anesthesia machines, and that room was incorporated into the new building, especially for conjoined twins. But it's only 2, not 3. But still, I think it's a step ahead. In my former institution, we had to adapt to prepare for these conjoined twins. So yes, what you're saying is very correct. It would be nice to have an operating room where you can automatically perform these surgeries, but then this is not something that you would do in each hospital center because these cases are rare. So I would think in places that do anticipate having more of these children, you can have such a center. Where I work now, they had good foresight, and when they were building a new hospital, they had that incorporated into it. But I think it does involve a lot of resources, so places like here in Saudi Arabia where you take care of a lot of patients, I think would be great to have that if you don't already, and a few other centers, but I don't know that each center can, you know, conveniently have that for financial considerations. But it's a great point.
Thank you. My question next is to Dr. Zawi. When I was in Toronto in the late 80s, early 90s, we used to use a lot with Zucker intra-abdominal expander. When I came back to Saudi, in the first few cases, before you came, we used these intra-abdominal expanders. I always asked Zucker why. He said, we also want to expand the fascia. And this got out of favor. Is this still in use or obsolete?
Thank you very much. I remember those two. I came just at your end of rotation, as you remember. Yeah, I'm not actually aware of any situation where we were stuck with an intra-abdominal ability to close our intra-abdominal fascia. Am I correct? I mean, we had other maneuvers. Putting an intra-abdominal tissue expander does have its complications. And whether adhesions, pseudo cysts that you are developing inside and affecting the general surgeons' work when they're pediatric surgeons when they're trying to work on the viscera. And I think the other maneuvers, just expanding the skin and the superficial fascia was adequate. Sometimes I think, if I'm remembering correctly, we can do the component separation in the abdominal wall, as you know, and that tends to help us with that. I have never read any recent experience of putting intra-abdominal expanders again. Do you?
One comment. I think the key is to put the tissue expander over something hard a little bit, either the ribs or part of the pelvic bone. Putting it over the soft tissue alone, it will never expand the skin and might pressurize the intra-abdominal organ. The failure with Roland Zucker is it was over the soft tissue. But all the tissue expander that we put for the thoracomphalobagus, we try to put it a little bit cephalic, where the ribs is under, so it will never pressurize the intra-abdominal organ, and it will help us in expanding the soft tissue.
All right, thank you so much, everybody. We'll keep other questions. You're going to see the speakers in the coffee break, so you can take more questions. In order not to hold people from coffee break, next.
Thank you to all our speakers for such an insightful session. Before we take a break, I would like to invite His Excellency Dr. Ziad Mamish, Senior Advisor to His Excellency Dr. Abdullah Rabi'a, to honor our guests.
Okay, thank you very much for this excellent session, and we would like to give a small token of appreciation to all the speakers for taking the time from their busy schedule to attend this meeting. So can we have the... First is Professor Olutin Olotai. دكتور مناف العزاوي. عبد الله الثنيان. دكتور سعود الجدعان. And Prof. Daniel. Thank you very much.
I think next session will be, it's almost 9:41, okay? So we'll start the session at 9:50 next door. Thank you very much.
Twins and their families. This side event aimed to explore the significant impact of separation on conjoined twins and their families. The separation of conjoined twins is a complicated medical and ethical procedure that goes beyond the separation itself. Recognizing the physiological, psychological, and social consequences for the twins and their families is essential for comprehensive post-op care. What we'll be doing in the next hour is to identify the physiological challenges and opportunities associated with separation of conjoined twins, focusing on the post-operative care, recovery, and potential implications. Also, we're going to understand the psychological status of separated conjoined twins, addressing issues such as identity information, coping mechanism, and long-term emotional effect on the separation process. We also will investigate the impact of conjoined twin separation on the family unit, including changes in the family roles and relationships. And then hopefully discuss the ethical challenges surrounding conjoined twin separation, considering factors such as autonomy, informed consent, right to live, and also the balance between medical intervention and emotional and social impact. And finally, we will explore existing support systems for families of separated conjoined twins, identifying gaps and proposing strategies for improving comprehensive care. So I have the honor of inviting our panelists, and we will start with Dr. Ahmed Bawana. He is a Director of Program and Deputy Country Representative at IMC Jordan's office. Mr. Bawana has over 15 years of mental health and psychological program management and technical experience in working with refugees and other vulnerable population. He has received his clinical training in mental health in the US and worked with different international agencies along with UN agencies in the field of child psychology and protection and mental health. So let's welcome Dr. Ahmed. And then we have Dr. Gopal Mitra. He's a global lead on disability and development and program group from New York headquarters since December 2022. He provides strategic and technical leadership to deliver on UNICEF's global commitment on disability inclusion across the organization. We also have joining us online Dr. Tarun Dua. She is the unit head of Brain Health Unit in the Department of Mental Health and Substance Use at WHO headquarters. And the aim of this unit is to promote optimal brain development, cognitive health, and well-being for all, and prevention and management of neurological disorders across the life course. Then we're delighted to have the Filipino Princess May and Princess Anne. Princess May is a third-year student at Kibo Technology University, where she is pursuing her passion for learning and personal growth. And Princess Anne is a third-year student at St. Cecilia College, where she is honoring her business acumen and creative skills. And we're also joined by her mother and the twin sister. And finally, we have joining us online Dr. Celia Christie Samuel. She's a professor of pediatric infectious disease, epidemiology, and public health from the Department of Pediatrics and Adolescent Health, University of West Indies, Kingston, Jamaica. We welcome all the panelists, and we're looking forward for a very, very interesting discussions. So we will start with the first questions to the twins. How did the experience of being conjoined and then separated influence your individual perspective on life? Maybe Princess May or Anne?
Hello. So, being a conjoined twins taught me to value a deep connection and cooperation as we shared everything and we also faced challenges together. After our separation, I gained a new appreciation for individuality and independence, while we still cherish the unique bond we always share with each other. It is a balance of gratitude for our shared past and excitement for forging our own path.
Thank you very much. And can we hear from the twin sister? Yeah.
So, how did the experience of being conjoined
Yes.
and the separate influence your individual? So, well, it has really made a significant change in our life in a way that it has allowed us to live normally, just like others. It made us feel included and like we belong. It has also made an impact on our emotional well-being, and it has made us more self-aware individually by helping us understand our limits and by living life separately with different groups of friends, different schools, and different workplaces.
Thank you very much. The next question is to Mr. Gopal Mitra. What lessons can we draw from our interventions in reducing stigma, promoting inclusive education that could apply to the unique needs of children who are conjoined twins?
Thank you, Dr. Ziad. And first of all, let me begin by expressing a deep appreciation for the Kingdom of Saudi Arabia for its leadership on the survival and well-being of conjoined twins. and to Case Relief for your dedication and commitment to the issue, and for organizing this important conference. At UNICEF, we are honored to be key partners of Case Relief on so many issues. Coming to your question, Dr. Ziad, stigma arises when, as individuals and groups of people, we assign attributes and characteristics to groups of people, including children, based on our perceptions and the difference that we see. Difference in the way they look, difference in the way they move, difference in the way they behave, they communicate, they think, etc. We often call them stereotypes. And as humankind, we are obsessed with normalcy, the notion of normalcy. So when we see anything that we perceive is not normal, we assign roles, attributes, characteristics to them. And stigma is particularly difficult to address because it is entrenched in deep social norms, our socialization, and our beliefs. For example, when a mother gives birth to conjoined twins, we already know the stress, the strain, the difficulties the family goes through. On top of that, if the community tells you that it is because of some misdeed in your earlier life, you imagine the additional stress it causes. Similarly, we have seen children who look different, who sound different, are often face bullying, they face exclusion from their peers, they face exclusion in schools, in the community. And the socialization gets impacted by that, which leaves a lifelong mark on the lives of children. At the same time, we know that addressing stigma is possible. Through decades of work in UNICEF on our social behavior change initiatives, we have seen that certain approaches really help in addressing stigma. For example, positive parenting initiatives, where we have successfully worked with parents through counseling, through peer support, really makes a difference. Training of frontline workers, early childhood educators, social workers, community health workers, working with them, addressing or raising awareness with them. We have seen that community engagement is a key approach to addressing stigma, where we have worked successfully with community leaders, with religious leaders, to address stigma towards groups and particular groups of children. And this is very relevant to conjoined twins. And what we also see work very well is role modeling. And we see our young friends here who are wonderful role models. So when we see children of a particular group doing well and leading regular lives, playing regular roles in their community, within their families, that really helps break stigma. Coming to the point of inclusive education, it is fundamental. Inclusive education is based on the premise that all children are unique. And the education is built on respecting that difference. So for example, specifically to the issue of conjoined twins, let's take for example, educational assessment. If we respect individuality, then we tailor the educational assessment according to the unique characteristics of the child, and in this case, the conjoined twins. We have seen several good examples around the world where if we take a sensitive, respectful look and thoughtful look at children, how they learn, then we are able to devise unique ways, tailor-made, customized for conjoined twins. And we see that it makes a whole lot of difference in the educational outcomes. So inclusive education is fundamental because it respects the individuality. It looks at adjustments and accommodations tailored to the need of the child. And it also goes on to use of technology, use of individual education plans, which are tailor-made for the child, so that the child can perform at her or his best. And overall, inclusive education is the foundation for an inclusive society. Thank you.
Thank you very much. We'll ask Dr. Ahmed Banaw about the challenges a therapist may face in addressing the conjoined twin challenges. And with your extensive experience in working with people who are needing psychological support, can you give us some guidance and advice?
Thank you, Dr. Ziad, very much for being the moderator for this session at first, and would like to extend my thanks to the Kingdom of Saudi Arabia for hosting such a great event and for the great hospitality to bring all of those people together to talk about very important topic that I think between all of the other challenges that countries are facing, I think it's one of those left behind topics, and it's important to shed some light on this. I think to start before understanding the challenges that people are facing, I think it's let's try and think of the challenges that go through the process from the beginning. I think it's a very complicated situation where parents and the twins also, they find themselves, they are facing from the beginning. And I think I would like to also echo what my colleague mentioned around the stigma, but on top of that, also this stigma doesn't go away after the separation. I think there are more challenges that we need to consider and we need to think of. At first, I think there are a lot of stigma coming from the way that the community look at those twins. I think also there are challenges that facing those twins and their parents when also they try and think of the process before the operation of splitting those, and during and the after. I'll go through those briefly. Before the process, I think a decision, making the decision is by itself is a challenge, and it's require a lot of information that unfortunately parents sometimes they don't have, and this causes a lot of stress. The same for during the procedures. I think there are needs for the multidisciplinary team, which I think a lot of professionals today, they stressed on the importance of this team. But the most important when we talk about this team is to look for their qualification and their competencies to deal with such unique situation. That's during also the procedures and preparing the parents and preparing the twins themselves, and also going through the process after the procedure. After the procedure is another long-term rehabilitation process that's required, and this also requires a lot of skills and a lot of competencies. Again, that maybe to start with asking ourselves, are our psychiatrists and psychologists and mental health professionals ready to deal with those? Is this something that we are getting used to it? I think the more by time, I think the more we will have successful cases, and those successful cases that will require a lot of support from our mental health professionals. With all of that, I would like to end my my very short speech about the importance of having professional that they are ready to deal with this, and also to be prepared for the stages that those twins are going through along with their parents. The importance of integrated mental health services along with different other services is important. It's very important that we don't deal with them as twins, but we deal with their stressors more than looking at them as only a special case. I'll stop here.
Thank you very much. I think this calls for a lot of training and development of skills of individuals working with conjoined twins in the healthcare facilities, and also as a follow to the individuals who have been separated. If I can direct my question to Dr. Celia Christie, who's joining us online. In complicated cases requiring prolonged hospital stay, how do you navigate the social support that is required by the conjoined twins and their families in these situations?
I was hoping to ask you that question. Essentially, in Jamaica, we've had 2 sets of conjoined twins to date. And the first set of twins were twins that were born, they were joined at the ziphisternum and at the abdomen and also at the pelvis. And essentially, we had issues as it related to dealing with the psychosocial issues because these babies actually died. One had a condition that was incompatible with life, and the other one died subsequently. We also have in Jamaica at the moment a set of twins that are in the hospital now for a year. They're Omphalopagos twins, and they are doing well in hospital. But the issue is with the family is that with mom has to take care of the children, and she finds it very difficult to visit. And she also has issues because she has to work and she has to take care of her children at home as well. So what happens is that we try our best to interact with and provide multidisciplinary treatment and care for mom. We assist her with try to give social support. We try to encourage her. She has actually gone on the television and she has asked for assistance from the communities. They have been giving her funds raising funds and so on to take care of the children. In addition, we also in the hospital we try to keep the children very, very healthy by to help mom to feel good by giving them not only taking care of their medical and care, but also paying attention also to their psychosocial support, nutrition. We give care and support as it relates to occupational support, play therapy to help mom to feel happy. And we have actually reached out to this program in the hope that you would be able to assist us to provide treatment and care for the babies. And I think this will help mom to feel very good if indeed this psychosocial support can be offered as we offer care and treatment to these babies abroad by separating them, because she really goes through a lot of distress. So
thank you very much.
I think that's what I would say.
Thank you very much. And this takes me maybe to the mother of the separated twins, and maybe if you can tell us how was the time of around the separation, and did you get the social support that you required, and how difficult was it in the perioperative period? Yes.
The support system that I found very helpful during the separation and recovery was my family being there for me. They helped me take care of the twins, so I could recovery faster the situation and made our family stronger.
Thank you very much. And now we will move to Dr. Tyrone Dua, who's joining us from Geneva, WHO headquarters. And the question is, conjoined twins are a high risk and vulnerable group. or having a neurodevelopment disability. Could you tell us about the approach that WHO advocates for following up any child at risk or with neurodevelopment disorders? You're muted. Can you please unmute? We can't hear you.
Oh, yes, I'm hearing you, Tarun. I'm hearing you very well.
We can't hear you. Can you try to unmute from your side?
Celia, can you speak and say that I'm unmuted and you hear me?
Okay, so we'll move on to the next panelist, and then we'll come back to Dr. Taron once we fix the audio. So again, to Mr. Gopal Mitra, how does UNICEF approach to thriving beyond immediate survival, supporting long-term integration for children with disabilities, particularly conjoined twins?
Thank you, Dr. Ziad. To understand the process of integration, we got to understand first what are the barriers that pose obstacles to the integration. When we talk about children with disabilities and other groups which are not perceived by parts of the community to be quote unquote normal, the barriers are, as I said, first in the attitudes in terms of stigma, in terms of social norms. The second is in terms of the environment, inaccessible environments, both physical and digital. And of course, the barriers in the institutional frameworks in terms of policies or the lack of it, and the implementation of it. And now, coming to the integration of children with disabilities, particularly conjoined twins, what is extremely important to understand is the continuum of care and support. And when I refer to the continuum of care and support, it means both vertical integration and horizontal integration. Let me explain what I'm trying to mean by that. So vertical integration, and in terms of the continuum of care, refers to the relevant care and support services that a child needs, the twins in this case needs, as they are transitioning to different life stages. So it's essentially a life cycle approach. If you see in terms of education, a child goes through 3 or 4 major transitions, right? A transition from early infancy to early childhood education, early childhood education to primary education, primary to secondary, and secondary to tertiary. On the other hand, it is from infancy to adolescence, adolescent to adulthood, and so on. So during these phases of transition, it is important that consistent, comprehensive, and holistic support is available. My colleague here spoke about multidimensional, multidisciplinary teams, which is extremely important. And that is where the horizontal integration is important, which refers to integrated holistic services across sectors. So we talk about healthcare services, health services that are required, medical services. We are talking about psychosocial support. We are talking about inclusive education. We are talking about how do we meet the additional cost that families bear when they have children with disabilities or conjoined twins. We are also talking about social behavior change and so on. So when there is a deliberate, intentional continuum of care that is holistic, that is one of the key ways or factors that impact the integration of children with disabilities and also conjoined twins in the society. And to do that, one thing is extremely important, is how do we integrate and build in data systems which speak to each other. For conjoined twins to count, they must be counted. And that, and the information, it should flow across these service delivery kind of departments Because if it doesn't, then it's very likely the children will fall through the cracks. So, so data is extremely important. The integrated vertical and horizontal integration is important. And one thing, we talk about technology. There are emerging technologies, which adaptive assistive technologies, which can really make a significant impact, a difference when we talk about integration of children with disabilities as well as conjoined twins into society. Thank you so much.
Thank you very much. These are extremely valuable comments and advice. We go back to Dr. Taron Dua. Hopefully her mic is fixed. Please go ahead.
Can you hear me now?
Yes, we can.
Great, yes. Okay, so I do remember the question, Dr. Ziad, you asked me, so which is about the approach WHO takes for high risk and vulnerable group for having a neurodevelopmental disability, in which we know the conjoined twins have that risk. So from WHO, there are 5 pillars, and I'm going to briefly mention the approaches that we follow. So first one is intervening early, and I think this is something that we have been discussing in the conference, that early intervention is the most important thing, because we know the rapid brain growth happens in the first years of life. And therefore, I think moving forward, it is very important that as we think about any of vulnerable groups, any congenital anomaly, that we have developmental monitoring as part of universal child health care. And what it means is a tailored surveillance to see if there is any issue related to developmental delay, and that access to evidence-based interventions could be provided. So opportunities are, for example, through immunization clinics, well child services, home visits that needs to provide that opportunity for monitoring and early intervention. The second approach is the holistic approach to care, and my co-panelists have talked a little bit about in terms of that we need to take a child family-centered approach, and and these include addressing issues like stigma, addressing issues like economic cost, and supporting the caregivers, because they may be they may have care. We know it impacts caregiver mental health. It may impact their functioning. There is stigma, and children may miss opportunities. So we need to be also be cognizant that the needs of the child, they evolve over time. It's, for example, the transitioning from childhood to adolescence. So that holistic approach is very important, and that's the second pillar. The third is the twin track approach to care. So what it means that we need to have targeted community care to meet the child's individual health, educational, and social needs, but then we also require that they have access to health promotive and care services. So for example, we have seen that, not only if you have developmental disability or any impairment, children do not receive basic vaccinations. And I think that is extremely important that we, again, have that twin track approach to care. Fourth pillar is about care coordination and having that multidisciplinary approach. I won't go into the detail because this has been talked a lot about in terms of within the conference, but I think especially if we are discussing conjoined twins, a care coordinator is very important, and that who deals with all the multiple disciplines in the health sector and beyond the health sector. And last pillar is the promotion of inclusion and participation. Stigma, my colleague from UNICEF talked in detail about the need to promote social inclusion, need to promote awareness, and this inclusive education is extremely important. Schools can be a good platform to take it forward. So I think that multidisciplinary, multi-sectoral approach is something that we need to strive for when we are thinking about any child with neurodevelopmental disability or at risk for neurodevelopmental disability. And so back to the chair.
Thank you very much for these excellent comments. I think the last question would be for Dr. Ahmed. What are the common mental health challenges facing the conjoined twins, and how can these be avoided in the future?
Thank you, Dr. Ziad. I think I'll start from the mother first. I believe during the pregnancy, there is a high possibility for the mother to know about this situation, and I think most of them, they know what they are going to face. And this is an opportunity for developing some disorders such as depression and postpartum depression as part of the challenges. Then when it comes to the twins themselves, after the separation, there is also, unfortunately, in a lot of cases, that one of the twins are going to be privileged. And this is a kind of something that would anchor some feeling of guilt of the other twin, because they are going to have, for example, more privileged than the others. And this is also especially when those cases, when like the bypass and the tripass cases, where, for example, there are 3 legs for the 2 twins, and that's part of the challenge. Overall, the developmental disorders is a high possibility for those twins, because in such cases, there are a lot of brain damage that may cause developmental disorders. The identity confusion. There are a lot of those, they leave the operational room and they were together as one, and now they are 2, and then there are a lot of confusion about the identity. And on top of that, also, there are a lot of anxiety, type of anxieties, like the general anxiety disorders that they may face, or the separation anxiety. Overall, and again, I would like to stress more on integrated mental health services with the primary care, and also the other team members like the surgeons and also the anesthesia doctors to be part of the multidisciplinary team. Then they can work together on those cases, and then they are aware of the developmental of those cases. Second, I think it's very important to build the capacity of the mental health professionals, and I have an example from Jordan, where the International Medical Corps, along with the King Salman Center in Jordan, we managed to build the capacity of mental health professionals to be able to deal with different cases like those, and that's part of the capacity building that required for our psychologists and psychiatrists and mental health professionals. By the end, I would like to end with trying and look for studies to be able to understand more about what potential risks that we are going to face in terms of mental health disorders, and then we can deal with that, especially that we are still learning about this topic, and especially also that we have a lot of opportunities for dealing with all of those successful cases that they were operated here in the kingdom. I'll stop here.
Thank you very much. These are very valuable comments. I think before we conclude, I would like to again go to the mother and the twin sister, and we're all interested to hear your special experience with the support system you have found during your dealing with the conjoined twin separation, and what was the most helpful part of these interventions that you thought were useful, and how did they impact your family? So maybe we can hear from the mother and the sister, and we'll take it from there.
Okay, thank you so much for that one. And also, I would like to thank for welcoming us today, and also for the challenges that we've encountered. Like, we do have like a sharp terms here in our family, but still we cope up to be stronger. And also for the challenges that we've made and for the adjustment, we would like to thank for helping us, especially to live my sister's life easier. And yes, and also for the chances that you've helped us. And also I would like to thanks to one of my Filipinos supporting us today, and thank you guys for the support. And yes,
Any comments from the mom?
The operation that took an emotionally toll on us, it was physically and emotionally tiring, yet we managed to overcome everything together by supporting each other.
Thank you very much. So I guess before we conclude, we want to celebrate for the two princes, Anne and Mia. I think they're in their third year of college now, and they're preparing to graduate soon. So we wanted to acknowledge their hard work and their studies, and acknowledge them with a cake that will cut with His Excellency Dr. Abdullah Rabia. His Excellency is on his way, so we're just waiting for him to... Thank you very much for all of you, and thank you for His Excellency for the kind gesture for the graduating conjoined twins or separated twins. And we look forward to continuing with the symposium and learning as we go. Thank you very much. And now we would like to appreciate the panelists, and His Excellency Dr. Abdullah Rabi'a will give them the small token of appreciation for their presence and for their participation in the meeting. We'll start with Gopal Mitra. Dr. Ahmed Banawa, UNICEF Jordan. IMC, sorry. And then the two conjoined twins. And the twins' mom. And the twin sister. And then we have two speakers or panelists online. We have Dr. Trona Doa from Geneva, and we have Professor Celia from Jamaica. I think we'll try to send you the gifts somehow. Thank you very much for your participation.
قد لا تكون حالاتهم مألوفة ولا شائعة الحدوث، لكنها حين تحدث فإنها تكون صادمة، مقلقة ومؤلمة. حينها يجب أن يكون هناك تدخل يصنع الفرق ويقدم الحل الذي ليس سهلا ولا عاديا. يستذكر أحمد ومحمد ذكريات تعود إلى 22 عاما، حين كان جسدا واحدا ملتصقين يتشاركان الحياة بكل تفاصيلها. قبل 22 عاما أجريت لأحمد ومحمد في الرياض عملية فصل جراحي معقدة جدا، استمرت 23 ساعة ونصف الساعة وكانت متتالية، وشاركت فيها فرق طبية متعددة. وقد تكفلت المملكة العربية السعودية بكامل تكاليف فصلهما وإعادة تأهيلهما على أيدي فريق طبي سعودي. قصة أحمد ومحمد تشبه قصة التوأم الملتصق داريا وأولغا من بولندا، واللتان تم فصلهما في الرياض أيضا ضمن البرنامج السعودي للتوائم الملتصقة عام 2005، وخلال عملية استمرت 18 ساعة ونصف الساعة وكانت متواصلة. التغيير الإيجابي الذي حظي به التوائم الملتصقون من عشرات الدول حول العالم والذين استفادوا من خدمات البرنامج السعودي لفصل التوائم ما هي إلا نماذج لقصص أطفال تعيد المملكة العربية السعودية صياغة حياتهم من جديد لينطلقوا نحو آفاق حياة طبيعية واعدة. كان عام 1990 ميلادية شاهداً على أول عملية فصل للتوائم الملتصقة في المملكة، لتبدأ معها قصة إنجاز سعودي متواصلة. منذ ذلك الحين قامت الفرق الطبية السعودية بفحص أكثر من 140 حالة، وأجرت أكثر من 60 عملية فصل جراحي بنجاح تام. استقبل البرنامج السعودي للتوائم الملتصقة حالات من 26 دولة ليصبح رائداً عالمياً في هذا المجال وموضع اهتمام الإعلام الدولي لإسهاماته وخدماته الإنسانية والطبية.
Saudi Arabia, conjoined twins. Twin girls in Saudi Arabia begin a new chapter.
Twins, that's Hussein and Hasna in Saudi Arabia.
Pinoy conjoined twins na dinala sa Saudi Arabia.
A Saudi medical and surgical team have successfully completed the separation.
استجابة مباشرة سريعة جدا، لأن هذا حدث إنساني وعندنا دولة وقيادة فعلا تترجم المعاني الإنسانية السامية.
ومن توجيه قيادة رشيدة وإلهامها إلى رؤية وطن تحفز همة شعب، يستمر نجاح هذا البرنامج السعودي الرائد عالمياً، حيث وفرت له الإمكانيات والقدرات والكوادر السعودية الخبيرة. توجت هذه الجهود بمبادرة سعودية نجحت في تبني الأمم المتحدة وإعلانها يوم 24 من أكتوبر في كل عام كيوم عالمي للتوائم الملتصقة. إنها حالات معقدة تم فصلها في الرياض لتكتب نهايات سعيدة لبدايات أكثر سعادة.
نشكر نحن الملك سلمان، نشكر محمد ولي العهد بن سلمان، الله يطولنا بعمره ويمدنا بعمره يا رب.
هكذا تواصل السعودية نهجها الإنساني في تقديم رسالتها للعالم بأن الإنسانية فوق كل اعتبار، لتمد بصمتها عابرة للحدود وحاملة بشائر الأمل لكل البشرية.
الحمد لله يا ربي.
I hope everyone enjoyed their break, and our next session is titled Long-Term Care, Rehabilitation and Family Support. This session focuses on the lifelong challenges faced by conjoined twins and their families including psychological care, rehabilitation, and social integration. This session will be chaired by Dr. Jabir Al-Anazi, a pediatric intensivist, and Professor Daniel Garris, a specialist in pediatric intensive care.
Assalamu alaikum. Good afternoon, everybody. Thank you for organizing the committee, inviting us to chair this session. Without further ado, I would like to introduce Dr. Esther Segal. She is a pediatric surgeon at Philippine General Hospital, and she has experience in doing the twin separation at Philippine. And we are present to present Dr. Esther. Dr. Esther, your stage. Dr. Esther, she will present about her experience at Conjoined Twin in Philippines, a single center experience.
Good afternoon, everyone, and thank you so much for this very kind and generous invitation to be here. It's such a pleasure to be in the presence of like-minded individuals who have made the management of conjoined twins their life work. So I would like to present the experience of the Philippine General Hospital from 1974 to this year. Sorry. Doesn't want to follow me.
It's not advancing. Maybe the battery is weak. Oh, there you go. Actually, he's going to try again. Some little technical issues, but
it will work.
There you go.
There you go. Thank you. So, just for the disclosures, I have no financial disclosures. I think everybody's aware that there's no money in the management of conjoined twins. A lot of hard work, a lot of satisfaction, but it's not something that you get return of investments on. In 2008, I was appointed the Conjoined Twins Coordinator for the Philippine General Hospital under the director then, and since then, it has never been rescinded. So my objectives are to present the experience of the management of PGH in conjoined twins, led by the Division of Pediatric Surgery. Conjoined twinning is often seen in fruits. I've seen it in mangoes, it's very common in bananas, even in lychees. I haven't seen it in vegetables though. In the Philippines, there's a very common rural belief that if a pregnant woman eats twin bananas, she will give birth to twins. So go figure. Even conjoined thumbs in syndactyly have been seen in some of our patients. So the earliest conjoined twins that have been recorded in the Philippines are that of the twins from Samar, that's the middle of the Philippines. They were the Godina twins in 1908. They were adopted by the Philippine ambassador to the US. And eventually, they got married also to twins and lived full lives in New York. In the Philippine General Hospital, a 1,500-bed state academic hospital under the University of the Philippines system, we have been managing conjoined twins, primarily indigent patients from all over the Philippines. So in the 70s and 80s, when we started managing conjoined twins, we only had x-rays and contrast studies. CT scans were available in private hospitals, but PGH is a public hospital. We only got a CT scan in 1989. And in 1974, through the efforts of the pioneers of pediatric, we call them the fathers of pediatric surgery in the Philippines, Doctors Ramon Ibay and Pedro Reyes separated on emergency basis Apaygopagus twins. Silas and Abednego were critical. One had a diaphragmatic hernia and was not expected to survive, so an emergency separation was performed. The sacrum and the urethra were shared, but they were separate bladders. The separation happened. It was successful, but unfortunately, because of poor neonatal care, the patient still succumbed. In 1984, the father of neurosurgery in the Philippines, Dr. Faustino Domingo, did an elective separation of craniopagus twins, and he did two. One was in PGH and another in a private hospital, and these were the CT scans of those craniopagus twins. I saw them in 2004 when Dr. Faustino Domingo did a dissertation on the twins, and they were alive with minimal neurocognitive deficits, but they were able to take care of themselves. So that was 1984. There was also a female thoracopagus twins in 1984 that were separated emergently. There was a hydrocephalus in one of the twins, and the patient was already critical and was not expected to survive. So the pediatric surgery service decided to do an emergency separation. There were no tissue expanders then, so the full chest skin of the poor twin went to the surviving twin. In 1997, that surviving twin became my patient when I was a fledgling pediatric surgery fellow. And I did surgery for adhesive intestinal obstruction. The patient had 4 breasts, and we offered to remove 2 to make her look more normal. But lo and behold, the patient and the family decided not to have the separation because it was the only memory of the patient and the family of the twin who gave her life so that the other twin would survive. So since then, 1984, few came in between. There are many types, mostly symmetrical. And when I was in general surgery training as a junior surgery resident rotator, I happened to be with the pediatric surgery division when the thoracopagus twins were being separated. These patients were very much in the spotlight because, as you very well know, conjoined twins like to be in the spotlight. In the Philippines, a lot of it has got to do with economics. Because when you get to be in the news magazine show, donations come in through the Red Cross, the Department of Health, and we did a very 8-hour surgery on these patients. They are now in their 30s, and they have led very productive lives. Inguinal hernias developed 1 year after the separation and were subsequently operated on. These were the CT scans, very new CT scans in VGH then, of these twins. We also did very simple Amphilopagus twins. These were the youngest twins that we did that both survived in, and that's because there was only a skin and fascia bridge between the two of them. One of our most lauded Scopagus twins were the Katubay twins of 1997. Again, I was now a pediatric surgical trainee. I had finished my general surgery training. I had to take care of these 2 patients for 2 years so that they would be able to be separated. Finally, there was already a spinal CT in the PGH. So these twins were female Scopagus tetrapus twins. One needed a PDA ligation because she was in heart failure at 3 months of age, so they were still together at that time. They also shared filum terminalis. The surgery took a lot of people there. The a neurosurgeon was there to help us with the separation, and it took us 28 hours to accomplish the surgery. Currently, because of the magic of Facebook, they chronicle their lives in Facebook. From being together, they are now both government employees in the island of Mindoro and living full lives. Unfortunately, we now know that Scopagus twins also have problems mainly with the genital tract, and it is something that we're still managing up to now. So it never ends. The treatment, the management never ends. And we have to be in constant contact with them so that we will be able to help them more. So we also had the craniopagus twins, but the mom was a nurse who sought help from Montefiore Hospital in New York. So they were accepted by Montefiore, and they were also celebrated in the US. They underwent separation and are now US citizens, still with helmets though. We had a bumper crop in 2016 of conjoined twins and parasitic twins, some of whom underwent resection, some were inseparable, and one that was a very big dilemma for us because our orthopedic surgeons who saw the 4 limbs of this patient could not understand which limbs were hers and which we could take out. So it was a very difficult case for us, but eventually we were able to perform the surgery after so much study. We also did an Embryology in 2019, and in this case, the viscera were mirror images of each other. These patients did not anymore require any tissue expansion. So in 2022, post-COVID, we noticed that there were a lot of twins coming out, and a lot of them were asymmetric and inseparable. One was this patient, who was actually a heteropagous, and that's, as discussed earlier in plastic surgery, the nice thing about having parasitic or heteropagous twins is you have extra skin, so you don't have problems with coverage of the abdominal or thoracic wall. This is how detailed it was, this heteropagous twin. Another twin was this patient. He was already 3 years old and had a very vivacious personality. So we were able to determine what legs actually belong to her through our orthopedic surgeons, and she has a meningocele too. So she is also she has difficulty in ambulating, but otherwise she is perfectly normal and is going to school. So these are the details of the parasitic twin. So these are the types of twins that we've been seeing in the PGH in the last 50 years. We have yet to see a rachypagos that is separable though. The only one, based on the Spencer classification, that we have not seen is the Parapagos diprosopus, and we're still waiting for that. How about the imaging? Well, as I said earlier, CT scans came late, but now we do have MRIs, we do routine ultrasounds, spinal and cerebral, we do Doppler images, CTs and MRIs, MRCPs for those with conjoined livers, 3D reconstruction. Recently, we've been playing with our ICG. So we're showing the cross-circulation, how fast the ICG goes from one twin to the other, and we make sure that we do meticulous labeling of images so as not to make a mistake when the separation is going to happen already. I have to give credit to the anesthesia team who are there. The surgeons come in just for the separation and all the planning, but the anesthesiologists are there from the imaging. They have to sedate the patients during the CT, the MRI, the MRCP, during the IJ, so they're there from start to finish until the patients are brought to the ICU post-operatively. So how about the separations? When we looked at the other data from other hospitals, apparently in Great Ormond in 2000, Professor Spitz reported that in 17 sets of conjoined twins, they had a survival rate of 80% in planned separations and only 28% in emergency separations, which is kind of normal, usual. We noticed that the improvement of survival rates is really dependent on how well we are able to delineate the anatomy pre-op, how the surgical techniques are mastered, how we do the body wall closure, and of course, never underestimate the ICU management. But it's really the experience of the entire team that will give us the success in conjoined twins management. So what opportunities have we had? Unfortunately, as we've seen in various data, there really are twins that are deemed inseparable. Who are these? These are the ones with complex cardiac unions, and we have one now. Those with extensive cerebral unions, and those with parasitic existence. There's really a moral dilemma in many of the team members who take care of the conjoined twins because they cannot stomach the fact that sometimes the patients will look really debilitated and will need lots of prosthetic management so as to be able to function well. So the question of why not leave them alone and separated always arises. In one case, Jehovah's Witness case, male Ethiopic typhus, the parents, realizing that the patients may need blood transfusion, refused further separation and management, and they were brought home with stomas. So the emphasis of the team with previous experience on conjoined twin management requires that you realize that the operative approach is never the same. Okay? There's highly complex anatomy, and even how good the pre-op imaging is, there may always be some problems intra-op. And we learned that the hard way just last week. Intraoperative changes in the management and implants will depend on intraoperative findings. So a wide range of specialists should always be on hand to be able to contribute to the management. And I've been very fortunate that being in an academic institution, I have all the specialties in my institution, both trainees and specialists alike, together, of course, with our nursing services. So what are indications for emergency separation? One twin critically ill, likely to die, or already dead, or there's a threatened survival of the better twin. This is often a contentious matter for some individual members of our team. So we enlist the help of our ethics committee. Sometimes it's so hard to call an ethics committee meeting when it's already an emergency separation that's being contemplated. So for planned separations, we don't have problems. It's comprehensive evaluation, expert evaluation, not just of the anatomy, not just of all the materials that may not be present in the institution. For example, baby tissue expanders we have to order, and it takes us 2 months before we can get the expander. So it really needs a lot of planning beforehand. We also need the expert evaluation in anticipation of reconstruction, and the reconstruction can take place over several years. So this is just a very nice diagram from SPITZ in 2015 regarding separation planning. Now, we're told that we want to separate us early, but you know what? I have a very hard time convincing my teammates to separate early because they feel that the babies might not tolerate the big surgery. So even if I show them all the data that everybody's showing, that we can separate as early as 2 months, 3 months, oftentimes we end up at 9 months to 12 years. So, okay, I told them, as long as they don't have the sense of self yet. So the feasibility of separation will depend on the organ connections, both vascular and major organ, and the management of the body wall closure. The performance of both hearts is often a problem and is the least predictable factor in our cases. So, over the years, as I've said earlier, I was thrust into the management of conjoined twins early in my professional life, so I've sort of become the team leader to coordinate everything. You don't have to be the expert in all the surgeries, but you have to be the expert in coordination. Knowing how to gather people, to enlist people, you end up becoming a lobbyist. To include the final decision-making after all the investigation and evaluation has been performed. And sometimes, despite all the exhaustive studies we've performed already, it's not unusual that anatomic abnormalities are still found intraoperatively. And sometimes this really destroys the flow of our separation, and we have to have a huddle again to find out if we can still perform, the separation can still continue. So these are just the general principles which have been elucidated earlier on. Our office is the MDC room. So whenever there is conjoined twins that are going to be evaluated, one of many twin meetings happen, and sometimes everybody gets to be present, not just the doctors, but also the nurses, even our orderlies, because we have to know how to do the transfers of these patients. We also have some rehearsals, and these were the actual dolls with detachable hands and legs that were used in the actual separation planning in 1996. Of course, we have Elmos, we can tickle them, and teddy bears in the most recent ones, and we involve the parents. The ones in the picture are actually the parents with the twins. We involve them in the simulations so that they will know what to expect. So although we've already evaluated more than 51, only 46 were actually underwent some form of surgery. So for elective separations, the majority, 75% are alive. And for the results, 50% of them are thoracopagus twins. That's the majority, followed by our ischiopagus twins. For emergency separations, we did this separation, and this was because of the death of one twin or the active deterioration of one. I don't know if it's very obvious there, but this was a 4-day-old omphalophagus twin, pseudomomphalosil. And the patient on the right already had a major cardiac anomaly, but this was not compatible with life. So we were just supporting the twin because there was a lot of dilemma from my team members as to whether we should separate ASAP or not. But eventually, when they saw that the pH of the patient on the right was already 7.01, they finally gave me consent to continue with the separation. And these patients had a shared bladder. We gave the bladder to the surviving twin, who is now almost 20 years old. In this other twin, the patient on the right is grossly malformed, and because of the active deterioration, we also did emergency separation with survival of the left twin. So the consequences or the results of separation of emergency separation of twins is not as good as elective ones, but it is a chance, particularly for the parents who would like to have at least, if they can't hug both, they can at least hug one of the patients, of their babies. So these were the conditions of the patients prior to the separation. There was already six who were already dead pre-op, 5 who died intra-op, and half who also died immediately post-op. Because sometimes when we do the post-mortem, when we do the post-operative meetings, we realize that the action to do the emergency separation was actually delayed, and better outcomes could have been achieved if the separation was performed a few hours earlier. So just some of the types who underwent emergency separation. And in timing, we usually perform it in 9 to 12 months, unless there's a very easy omphalophagus twins, because it does provide us time for the preoperative assessment, the integration of all the specialists involved, and the procurement of some very special supplies. Anesthetic management is also much easier for our anesthesiologists, and blood loss and physiologic derangements are better tolerated. For the timing, we noticed that any separation, urgent or emergency-wise, before 6 months have a higher mortality. On the other hand, if you try to separate beyond 3 months, as in earlier sessions, yes, they do have a problem with their codependency. So we separated 3-year-olds and 4-year-olds, and they were thoracopagus twins, and they were looking for the twins. So we had to separate their beds such that they were facing each other so that they would not miss each other. And when they were already extubated, we had to put them in one bed so that they could each play with each other as they had done so when they were still together. So I noticed your hospital has 100% survival rate, and we said, wow, congratulations. This is really excellent results. In Cape Town, it's elective surgery. They also have some mortalities. So the elective surgery survival is only 50%. Earlier on in Great Ormond. But this is all data. In PGH, for elective separations, it's 75%. But overall, because of the deaths in our emergency separations, the overall survival is only 46%. So just a graph to show that. So newer imaging methods have been there, and we've been doing 3D reconstruction. We don't have a 3D printing machine in the hospital, so an orthopedic surgeon brought his own, and we just pay for that, that plastic thing that gets to be developed. We've also experimented with ICG. So recently, in the last twins that we did, our orthopedic surgeons did a 3D cast, printed 3D cast, so that we could plan the pelvic reconstruction better. So how about ethics in management of conjoined twins? Philippines is a multicultural area, so we have to take into consideration all the belief systems of everyone, including the patients. So we take into consideration the family goals and wishes, the benefits and burdens of separation, all considered, financial, social, and religious. Where the timing of the separation is often a dilemma, even for the medical team. Some want them bigger, some want them after 2 months, after 10 months. They can't even give me a good reason why to delay the separation any further. And we shy away, we do not like to use the word sacrifice. Because once someone says the word sacrifice, the bad twin, the dying twin, the deteriorating twin, then a lot of times the term becomes unacceptable to some of the medical team participants. So, yes, conjoined twins are very actively managed and they can be often in the public eye and was thrust against my will because when you're a fellow in training in the Philippine General Hospital, you get pushed. When there's a reporter, you talk to them. So I had to talk to them. So as early on as a resident physician, I was already handling the PR for conjoined twins. And until now, it remains my responsibility. So whether they're separable or not, I do all the coordination. I've also had the occasion to coordinate for international collaborations. So for conjoined twins in the Philippines is an archipelago. It's 7,100 islands. Not everybody has very good healthcare, just even for primary. So many lack access. When I say access, not just the hospital, even having transportation, just to transfer to a center. If you're born in the islands, you're not prenatally diagnosed. We had been pushing for a prenatal congenital anomaly ultrasound to be part of the newborn package, but it has not yet been enacted. There is lack of specialized diagnostic imaging, even in some of the major centers, even in Manila, the capital. And financial incapacity is being addressed now. There is now universal health care, and the government does take care of its own, particularly when it comes to congenital anomalies, but we know that the resources are still subpar. In my country, politicians and journalists are often approached by these families, by the local chieftains, to seek assistance with the financial aspects of the care. I'm sure everybody has heard about this, but I was so distressed when I saw this when I was watching this news. And it's having the price of self, being the individual. The Crinophagus twins from Iran, the Janet twins, they so wanted to be separated. They so prized their self, the individual. They were willing to risk their lives. And as a result of that, they died from intraoperative blood loss. So we were saying, my gosh, but who can make any decisions? Who can make any judgment in this case? No, it was the patient's wishes. They were already adults at that time. On the other hand, there's the Hensel twins. They're now in their 30s. They're diencephalic. They have been told they're inseparable. They had a third arm taken out, but they finished college. They're working as primary school teachers, and they've already given birth. So I feel that they're really the success story of conjoined twins, whether they're separated or not. So just my thoughts. It really has been a privilege through the years to have been part of being involved in the care of these very special patients, and of course also their families, and have kept in touch with them through these years. They really deserve our compassion, the empathy, and the understanding, but we also need to continue learning from them so we can also improve. We have to use this knowledge to help in the care of future twins, and that is why I'm so very happy to be here, because I am also learning a lot. These are not things we discuss in regular pediatric surgery conferences. Multidisciplinary collaboration should never be overemphasized, and lifelong surveillance may be necessary for very complex cases. So just a summary, an accurate preoperative investigation and team approach, wealth of experience, and meticulous planning contribute to success of management of conjoined twins, and the death of one of twins before the planned surgery can have a severe impact on the other twin, especially when shared organ circulation and cross-core circulation is significant. and prenatal diagnosis is ideal for better planning. So there was a time that we had 3 conjoined twins in the hospital at various stages of management. The first one still with no expanders, the middle one already being expanded, and third one, the esophagus twins that we eventually had to forego separation because of the lesion. So conjoined twins are indeed very fortunate to have found their champions here in the Kingdom of Saudi Arabia. Thank you for all that you do, and congratulations again. Thank you.
Thank you very much, Dr. Esther, for your presentation and sharing the great experience with the audience about your experience and your team. Our second speaker is Dr. Ali Al-Shehri. He is a senior intensivist at National Guard King Abdullah Specialist Children's Hospital, and he is going to speak about challenges in post-operative and critical care. Stage is yours, Ali.
Assalamu alaikum. Good afternoon, everybody. It is a great pleasure for me to present for you today in this well-respected conference about the challenges in critical care. I think over these 2 days we learned a lot from our colleague from surgical perspective and from the preparation. And there is a new journey will start for the twins after separation in critical care until they get discharged home, then they got their rehabilitation. So over the next 15 minutes, I will try to speak about PICU care for conjoined twins, and I will try to highlight some 7 challenges that I think it is very common when we deal with them. I will highlight also some analysis for our pediatric intensive care database for conjoined twin, where we could analyze 24 set out of 61 has been operated in our hospital. So when we receive a conjoined twin in our ICU, this is the thing that we do for them. It's a common ICU care for any surgical patient. We do monitoring, sedation and analgesia, respiratory support, hemodynamic support, fluid management, wound care. We maintain the hemostasis and we treat the infection, and we'll try to reduce the ventilator-associated infection. We try to introduce feeding and nutritional support, which is really, we provide this for all surgical cases. What is important for conjoined twins, for intensivists, the knowledge and the skill to have a family counsel and support. It's important to know how to deal with ethical issues resulting from the separation, because most of the mortality and many things related to the palliative care occurred in the critical care. So it's something that we need to watch it when the patient came to our unit. We admit those patients in King Abdullah Specialized Children's Hospital. We have already 61 set twins separated since 1996. And the unit actually is a big unit, has a 28 single beds covered by consultant 24/7. To care a conjoined twin, we are doing this in the multidisciplinary approach. So it's not only the medical staff, there is a well-trained medical staff, there is a nursing staff, that's a clinical pharmacist, respiratory therapist, there is a rehabilitation staff, dietitian. All this has been well-trained and has very good multidisciplinary approach to care this post-operatively. We build our conjoined twins database, and today, as I said, we'll try to present the analyzed cases, which is around 24 cases. The first challenge that we face regarding the rarity of the disease, so there is no standard post-separation care protocol. So if you go in any institute, everyone is practicing by experience. So most of the study in the literature, it is single institutional experience. So the highest number probably is around 10 to 40 set has been reported in each cohorting study by institutions. Most of study of an observational study and case series. So for these purposes, the practice in ICU, it's clinical based and based on our experience and the experience we are have it from the other institute. We focus mainly on the general organ support. So nothing specific or particular to care with those patients in terms of the general hemodynamic or respiratory support. The other challenges for conjoined twin, they are not one spectrum. As my colleague presented over 48 hours, there is a different types and a different shared degree of shared organ. There is different anatomy and physiology the separation planning also. We got conjoined twin in ICU. It happened after high emergency separation, and as stated with my colleague earlier, the mortality exceeding 80% in those patients. And we have sometime got them conjoined, they came admitted for a stage separation or after procedure intervention. So they came, we have two bodies that we have to deal with them, and this is require delicate knowledge and skill to know about the physiology of those twins. And commonly we receive them after separation, so we deal with them like a two different patient in ICU. Also the comorbidity, it is different. So also my colleague talk about high risk comorbidity like cardiopulmonary comorbidity, which is the most type of morbidity that affecting the post-operative care. Most of patients who got thoracopagus or has chest connection, they stay longer with us in the PICU, and they need very delicate management to their cardiovascular and respiratory system. So make all these variety of cases, make the knowledge also from the ICU staff or the team who's handling the patient to know all these type and understanding their physiology before the patient arrives to the ICU. To overcome of these challenges, actually, I think my colleague has overemphasized the multidisciplinary team, but what's important to us from ICU point of view, that the intensivist should be part of that team. So the ICU nursing team and also medical staff team should be a part of this multidisciplinary team to understand all these challenges that I talked about earlier. Our engagement, I think this is an important factor, this is the most important factor for success rate post-operatively. Our data shows that the success rate of separation of the child, which is commonly a planned surgery, it is more than 90%, which is excellent. This is one of the highest survival rate in all the cohorting study worldwide. Which is relatively 60 to 8%, and we're exceeding this. Based on this variability among the cases, the focus of management post-operatively, it is individualized case care. So every single twin, it will be treated like different from other twins. So we get prepared, we understand the physiology, we know what happened intraoperatively, we understand the cardiovascular and respiratory status, then we provide a focused care for individual twins. The third challenge that we face is the magnitude of cross-shared circulation. I think obviously that could be determined clinically. We know that in common cases, thoracopagus and craniopagus type, they have a common shared circulation. It's sometimes unpredictable. I mean, you can see higher shared circulation compared to what we see in their pre-op evaluation. But this has definitely affect their management post-op, whether they came for you after stage surgery because they still have the communication and the circulation, or also the physiology could be changed after complete separation. And we have to be prepared for this because the physiology Post-operation, it may be completely different when the shared circulation exists during the pre-separation. So based on the shared circulation, the physiology of the heart and the cardiac output will be different. It will affect the drug response. My colleague spoke about it. It can cause cross-effect of medication. You give medication to one child and you see it in the other child. Commonly, we have to electively intubate one patient because there is another, the other connected child gets acute sickness and has to be intubated because we know the effect of the cross circulation. It's commonly we give a patient to one twins inotrope to push his blood pressure up, and the other one will be hypertensive. Then we have to deal with this actually when the patient is shared. Also, their shared circulation and the effect, it will not be consistent. What you see pre-op, it can be reversed or completely different, and you have to be prepared post complete separation. We have this case, two twins, craniovagus. I guess we have like a, yeah, there was a connection, if you can see the venous connection between the two twins, but actually when they go for stage separations, you can see the left ventricle is completely dry. It is almost hyperdynamic and very collapsed left ventricle because all the blood, all the fluid that given to that patient was shunted to the other twin through the huge communication in the venous system. So that twins, which is twin P, end by huge resuscitation. I remember we gave him more than 150 ml per kg to try to keep his cardiac output. But all this fluid was go to the other child who's become hypertensive, and we have to use labetalol to control his blood pressure, and he's become polyuric. This situation, especially post-stage separation, it takes time to recover. So they need to be supported with vasodilator for one twins and the inotropes for the other twin who is hypovolemic, and until they get adapted post-operatively. But it's really challenging controlling the hemodynamic in a patient who got shared circulation. Post-operative, after the complete separation, actually this has been recovered, but it is recovered slowly. It takes time to support with inotrope until the patient get their norms after the surgery. So what we are doing for this to overcome this challenge is actually we individualize the estimated weight for weight calculation for every patient. So we divided the total weight in two, then we give it, we calculate based on the individual weight, the medication, everything. If one of the twins is smaller, then we estimate the proportion of the weight. We give the balanced fluid, we give inotrope and vasodilator support to achieve age-based physiological parameter, and this is an important because the physiological parameter could be different pre-op. So post-operatively, we have to target a age-based physiological parameter, not to have supra-physiological target in terms of heart rate, blood pressure, and saturation, and to have optimal organ perfusion, and we look for many markers post-operatively to assess the cardiac function. We try to target lactate less than 2, mixed venous saturation 70, urine output more than 1.5, and sometimes we need echo to assess the ventricular filling to assess the volume status on this patient. Drug monitoring is important when the shared circulation exists. And sometimes the shared circulation, it could affect the absorption of the feeding. So sometimes patients, we need the central lines and to have to TPN to get him to enhance his growth. The fourth challenge is I think my colleague, they talk about many risk factors. The many risk factors that may predict the patient may be sicker post-operatively. But however, this is not consistent. It can be different because different variety and different complexity of the single twins. So the thing that we know from the literature and from the previous experience, age of separation less than 3 months is very high risk patient with thoracovagus because involvement of cardiopulmonary system, emergency separation, those patients getting sicker, having comorbidity. Cardiac by far is one of the highest risk for the complexity and sickness after the surgery, pulmonary anomaly, renal impairment, and also large shared circulation. There is intraoperative factor, which is, I think it is important important and crucial for the course post-op, like length of stay, massive blood loss. That's important. I think that's something that we could control within the surgery. And using of inotrope, likely patient who you start him inotrope during surgery, likely to be sicker and continue post-operatively. Operative factors, tight closure. People say it's important to have a good skin for closure, because tight closure, it could happen in children less than 3 months, could compromise cardiopulmonary function, and those patients frequently present with acute abdominal compartment syndrome. We have 2 patients at least who we have sent them back soon after surgery to release the abdomen to be able to ventilate him and ensure to provide good cardiac output. Large skin defect is really challenging because we have to keep patient ventilated longer, and also massive blood loss that result from this open skull. And frequently we got unpredictable findings inside the OR, which impact our course after surgery. So our data, when we analyze those data, we got good survival actually for the patient operated less than 6 months. We got 12 patients operated less than 6 months. However, only 1 patient less 3 months. So we cannot make any conclusion about having a good 100% survival for those small patients. But obviously, 3 to 6 months, maybe it's a good age to separate a child, and that will be different from a child who is separated after 6 months. We look for the patient who receive blood transfusion, and obviously, patient who got massive bleed, more than 40 ml per kg, it's more likely to end by inotrope, and we're getting more sicker post-operatively. We look for also people who get a skin graft or mesh, and obviously from data it shows patients who have a mesh closure and for more prolonged mechanical ventilation. So I think the best approach may be either do complete closure or with skin flapping based on the complexity of the case. But I think it's not a good thing for ICU perspective to get a mesh because it is prolong the ventilation of the patient. Ventilation, when we look for our data also, we found a good percentage of patients, they don't require mechanical ventilation after OR. In the past, we thought every separated twins has to come intubated. But we found a few proportion of patients. Maybe this is part of the good pre-op evaluations and anticipation the risk, but there is a good patient who could come to us without extubated from OR. And when they came, 66, they require all type of ventilation. So you could ventilate them through non-invasive, from mechanical ventilation. Few proportion of patients may end by severe hypoxemia, and those usually people who got thoracopulmonary problem and may require high frequency to ventilate them. Given the fact of the sickness and the type of the conjoined twin, we noticed that the higher length of stay, it is linked for patient who got thoraco-omphalopagus and omphalopagus patient. And that I think it is expected because presence of the cardiopulmonary. Other patient, interestingly, the length of stay in our unit at less than 2 weeks, which is an excellent outcome, except for those 2 patients, omphalopagus and thoraco-omphalopagus. And interestingly, the parasitic twins also, they spend long time. They spend up to 1 month in the unit, and I think probably usually when you get parasitic twin, the other twins has a very complex anomalies. So overcoming of this predictive or uncertainty about this and variability, when we saw them post-operatively, we tried, as we said, regular monitoring to the fluid, blood gas, drain, output. Every single drop out of the patient, we have to calculate it from any source. And every single drop of a fluid going to the patient, we have to look at it and calculate it. The other thing, the decision is clinical-based decision. There is no gold standard care. There is no evidence-based science to support any specific intervention. The target value is physiological, and also the organ support, it is we try to target the protective lung strategy, like good wound care, hemostasis, and iovolemia. Then we treat also the organ failure once it has happened, whether with mechanical ventilation, dialysis, or if we got blood product to maintain homeostasis, or diuretic if we got a patient who is overloaded. Fifth challenge is the massive capillary leak. We saw this almost on all the patients. So patients who came to us from OR, especially in the first 24 hours, all of them hypovolemic. They need to be resuscitated with the fluid. They got a massive leak because capillary leak, intra-abdominal leak based on how big the surgery, large wound defect, that's very contributing factor, and surgeon sometimes they use the vacuum to help the healing, but ultimately it will end affecting the fluid losses, and we have to replace this. So also the bleed, and we balance this with presence of comorbidity. So fluid loss has to be balanced with the cardiac defect or renal impairment. So actually that's an important when we monitor the patient to adjust the fluid. And our practice, we put a patient in 2/3 maintenance, input and output hourly. We correct volume depletion, we replace the leak, and we provide blood product if needed and diuretics for volume overload. If you see how much drain patients get after the surgery, it is a lot. Vacuum, I mean, we get like vacuum in 20% of our patients to enhance healing. But they have all different type of catheter that we need to look at and take care of them. Non-surgical complication, it's interesting, the post-op course, most of complication, it is not surgical, it is a medical. So sepsis by far is the most common complication with different sources, from the wound, from the central line, from the lung, and we have to take care and provide a good surveillance and bundle to prevent the infection in the post-op care. ID expert, I think it should always be in the board because also the complexity to for the source of the infection. Last challenge is which is something that we see it commonly in the twins, the pharmacological what medication that you give for sedation or analgesia is not different from any patient post-op. However, for twins in particular, we provide a calming down tool when they extubated. We have to put them in one room. And they will calm down immediately, and the feeding will be enhanced immediately when they become close to each other. So we get them from, we don't keep them into room after extubation. There is interesting in the literature when they spoke about mirror alongside the survival twin. So if one of the twins has been died for any reason, just putting a mirror close to him, he will get calm. So in summary, or the home messages, the preoperative multidisciplinary team is overemphasized, is important, it is critical for success. Shared circulation have variable effect, and you have to be prepared for the changes post and preoperatively. Post-separation ICU course may be unpredictable, so you have to get prepared for any changes in hemodynamic and provide a targeted therapy. Clinical-based approach, that's really what we are doing. Age physiological target and optimal tissue perfusion is the goal of treatment. Risk infection extremely high. Fluid management is crucial for recovery. Thank you very much.
Thank you very much, Dr. Ali, for your presentation and highlight the critical challenges in critical care. Our second speaker is Dr. Nizar Al-Zaghabi. He's a senior pediatric anesthesiologist, and he's going to speak about fast-track extubation and new trend. Thank you, Dr. Nizar, and the stage is yours.
Thank you, everybody. It's really interesting to hear the previous talk, Ali. I mean, this is really keen, and there is lots of interference and lots of overlap between us. So imagine sending you a patient not intubated. I'll help you a lot. Okay? So I'm going to talk about a new trend that we're trying to establish in conjoined twin surgery. We know what's ERAS. ERAS is enhanced recovery after surgery. It's a holistic approach to the patient, focusing or tailored to each patient separately, and it's with evidence-based strategy aiming to reduce the stress in the preoperative period, physically and psychologically. So it looks at the patient, take the patient preoperatively, take him to intraoperative and postoperative period to optimize certain stages to enhance recovery. For example, in preoperative, they encourage education of the patient. They encourage shortened fasting, carbohydrate intake, All these things enhance recovery after surgery. Intraoperatively minimize the anesthetics, fluid management, meticulous fluid management, avoid overhydration, especially for bowel surgeries. Afterwards, early mobilization, early extubation, and discharging the patient as soon as possible. So this is ERAS. This is the trend over the last decade in anesthesia and surgical perspective, trying to minimize the patient. One important factor is pain control. Pain control is an essential factor that has to be addressed in all surgeries in order to minimize the stress on the body. ERAS has positive outcome on the patients. It's a faster recovery and shorter hospital stay, reduced perioperative complication. Of course, this will lead to lower cost and improved patient satisfaction. One of the steps for ERAS or early extubation is, for ERAS is early extubation. If you extubate the patient as earlier as possible, you can have a better outcome. So with that, you improve respiratory function, nothing like breathing spontaneously rather than mechanical ventilation or positive pressure ventilation. It reduces complication. It enhances early mobilization, ultimately leading to early reduced hospital stay. All these are the same targets of ERAS. We are anesthesiologists. We aim for homeostasis, everything back to normal. So what's the extubation criteria for any patient? Patient has to have a vital signs, has to be normothermic, has full recovery of anesthesia, especially neuromusculars, blockers, has to be reversed, has to have spontaneous, adequate ventilation with good tidal volume, and adequate pain control. Again, I emphasize on adequate pain control. So pain control can be done differently in the ORs. Mostly we use intravenous medications like morphine, opioids, or non-opioids intraoperatively. However, still, I believe regional techniques are more superior in blocking the surgical response intraoperatively. We have tried in the conjoined twin different kinds of regional techniques. We have tried thoracic epidural, especially for thoracomphallopagus. You need a higher block. So with that, we did thoracic epidural catheters and we inserted. However, it's challenging. Why it's challenging? Because you put a catheter, you put an upside, there's a surgical prepping, there is in the ICU care, leaking afterwards, so it wasn't very successful experience. In spite it was done in probably 4 or 5 sets of conjoined twins. Another approach, which used for mostly younger children, neonate mostly, is the thoracic epidural catheter via caudal approach. There's a caudal space in the lower sacrum for the children. We can thread an epidural catheter and spread it up high in the thoracic area and give you a higher block. So this is an option has been done. Again, the same problem. Catheter is a problem because you put an upside, you have to keep it for a few days, and the incision, mostly for esophagus and omphallopagus, is around, especially when you do a 360 prepping and draping. Another approach has been tried also is a caudal morphine. We all know morphine is a water-soluble opioid. When you put it in the caudal space, it diffuses to the CSF and it migrates up and even if you put it in the caudal space, it can reach the brain. So it has a good analgesic effect for post-operative and intraoperative period. So after 30 years of experience, of 3 decades of conjoined twins, and the science has developed, the techniques has developed, ERAS came in the last decade. So the question arises, can we do that for our conjoined surgery? Can we do that? Remember, conjoined surgery are a complex procedure as explained by my colleagues today and yesterday. It has lots of complexity, surgically, anatomically, logistically, prepping. You can see all, I don't know, where's the laser? I don't know. You can see how complex the team are there. In addition, in the lower right corner, you see a big incision. It's covered, of course, for the picture purposes, but you see how incision for the esophagus there. And the patient could be exposed to hypothermia because the wound, the abdomen, it's all outside, is even in spite of aggressive warming up the room and aggressive active warming, still it does happen. In addition, it's a very painful procedure. So let me share our experience with 8 cases. We've done in our center for the purposes, we've done 61, but for the during the presentation, preparation was 60 cases. 8 conjoined twins, or 8 sets were done. 5 of them are conjoined twin and 3 are parasitic. And the average age were 11 months of those people. Those cases are extubated in the OR. The 8 cases are extubated in the OR with an average weight of 6.3 kilogram. The interesting part, the duration of the surgery is 5 hours. Majority of those cases were extubated. Among those extubated, we had caudal morphine, which is around 62%. The first dose in the first 24 hours, after they went to the ICU, it's about 1 or almost 2 doses they got. The first rescue dose was 10 hours after the procedure. There are 2 cases of omphalophagus. They did not receive any medications in the first 24 hours. Luckily, the complications are minimal. There were no reintubation in the ICU, no side effect, hypoventilation, nausea and vomiting. And average PICU stay, Dr. Ali, were 2 days, 9 hours, compared to the others, conjoined twin, that they were intubated, that lasted for up to 40 or 90 days. This is another factor that we look into, the amount of fluid given, because also the amount of fluid will reflect on the closure of the abdomen. If the bowel is distended with lots of fluids, it makes the closure very difficult, and that will increase the intrathoracic pressure, making our extubation more challenging. So among those extubated, 50% received blood and 60% received colloids. And the surgical duration, we have discussed that before already. So, if we take a journey of our patients, preoperatively we decide, or predict probably, and we're going to talk about that, who do we predict, which one will be able to do for the fast track and extubated in the OR. Then we go on to the complex course of the ORs. Then we extubate. This is a set of, I think, the Filipino conjoined twins. And you can see that the surgeons are carrying the patients for the group photo. Then we handle them to the patient. Once we lift outside the OR, the mother was able to hold her child. Imagine the satisfaction and the psychological relief for the parents and the children if they're more awake. And this is one of the girls. This is in the OR, by the way, the picture, the photo in the OR. We're waiting for the other, her sister they finish prepping her, putting the bandages and leaving the OR. As I emphasize again, this is our anesthesia plan. We have plans up front, and it's in the anesthetic plan, we plan that this patient will receive caudal and the amount of caudal. So the anesthesia team, knows about it. So one of the questions talking to my colleague Dr. Azzawi is say, how do you predict, or are there any predictors? To be honest, we tried mostly in the omphalophagus cases, and there are, as I told you, there's thoracomphalophagus, there's ischio-omphalophagus, but mostly it's omphalophagus and parasitic twins. But we need more research, I think. We need more research and develop more criteria to predict which cases that we can do. But of course, it depends on different aspects. The surgeon, the surgical procedure, the duration, the amount of fluids and blood transfusion, and the anatomical variability of the children. Okay. Because even if they have sacral agenesis or sacral anomaly or tethered cord, we can't do caudal morphine for them. We have to choose another modality. So in conclusion, ERAS after conjoined twin separation is possible and safe. We need to have better criteria for patient selection, and of course we need to provide good pain control in discussion with the multidisciplinary team. Caudal morphine has been proven in our series here that it's effective and safe, and however, we need more criteria to set to predict extubation and as a fast track. Thank you so much.
Thank you very much, Dr. Nizar, for this exploration about ERAS and conjoined twin surgery.
The next speaker is Dr. Alzir Al-Nouri, a pediatric complex care consultant, King Abdullah Specialized Children's Hospital, Minister of National Guard Health Affairs in Riyadh. And she's going to talk about long-term care and rehabilitation. Welcome.
Hello, good afternoon, everyone. Good afternoon, and thanks for His Excellency and Scientific Committee for inviting us and sharing our experience. My talk will be focused about the long-term care and rehabilitation. So the focus of my talk, it will be talking about what is after separation. So just none to disclose, and all photos in the presentations, consent has been obtained from the families. So as we've been hearing from yesterday and today about the conjoined twin journey, it's been divided between the pre-separation phase, separation phase, and then the post-separation phase. Keep in mind that each phase is interconnected and each phase is really affecting each other. So the post-separation journey is started immediately after separation. So immediately the patient will be in the PICU, so they'll be receiving the immediate care, as Dr. Ali has been mentioned and extensively explored about that. Then after the separation from the critical care, and the patient will be able to be shifted to the inpatient surgical general ward, we're receiving most of the care as a post-separation. After the stabilization, then the discharge planning will be started, and then we'll be going to send the patient home, and then the outpatient care will be started. So in general, as we've been hearing from yesterday and today, that the survival rate of conjoined twin in general is between 5 and 25%, and the overall survival rate after separation is about 60%. Can be less or high, depend on the complexity and the type of the conjoined twin. Most related death post-separation were related to cardiorespiratory failure, congestive heart failure, sepsis, and infections, apart from the congenital anomalies that each twin may have. So the focus of the goals of the post-separation care is to promote recovery and observe for any complications, promote development and growth, develop routine daily activity that they can obtain and have home, maintain the mental health well-being and the quality of life for the children and for their family too. So the post-separation stage is a very critical stage as the separation, as the pre-separation, because most of the life care will be after this stage. So it has its own challenges. Maybe it's shared with the separation and the pre-separation also, but in particular, we will challenging about the medical, nutritional, psychosocial, rehabilitation, and the development, which we'll be talking briefly in each one of them. So in general, as we've been hearing from yesterday and today also, that the success rate of the separation surgeries can be varied. Also, the long-term outcome can be varied. And it's really affected by multiple factors. So by reviewing the several publications and the past experience that we're having in our hospital and institution, there are a lot of factors that affect the long-term outcome, and then it will shape the long-term care. So the type of the conjoined twin, the complexity of the shared organ, the age of separation, the baseline health status of the twins, if the separation was electively or emergency, and the post-separation complications. I'm not going in detail on all of them because it has been extensively elaborated from yesterday and today. So let's start with the medical health. So shortly after the separation, the most challenges it will be have about the wound healing and the infections that might need some surgical intervention more. Also pain management and the mobility restrictions that require tailored rehabilitation plans to ensure the optimal recovery. After that, so I'm going to talk about each type of conjoined twin with the most common ones about the long-term outcome. So from the SQ-PEGs, as been hearing today from the talk from our colleagues from the surgery, that the most challenges for the long-term outcome from the SQ-PEGs is about the reconstructive surgery, mainly for the musculoskeletal, genitourinary system, biliary systems, and the potential of they have a recurrent UTIs based on the genitourinary sharing system from that. So the reconstructive surgery is a very important in SQ-PEGs conjoined twin post-separation. Regarding the cranio-PEGs, it's range from minimal to significant disability, mainly affecting the motor and the cognitive. It depends on the degree of neurological sequelae or the complications due to the shared blood vessels and the brain structure. For the omphalopagus, usually the long-term outcome is good, but again, it's really related to the GI shared system and the biliary system. From pyopagus, it also depends on the involvement of the spinal cord, anal canal, and genitourinary systems. Most of them, they have normal autonomic and neurological function, but they might have some issues with the fecal and urine incontinence, also with positional scoliosis. One of the major things that I would like to highlight is the infections. So our conjoined twin, they are a very high risk of multiple infections due to multiple factors. They are coming from different countries with different infection profile. They have prolonged hospitalization, either in our institution or from the country they are coming for. Some of them, they are coming directly from hospital to hospital. The use of the foreign bodies, for example, the tissue expanders. That's why we heard yesterday from surgical team that they are trying to limit the use of tissue expanders, and they use it only for special circumstances. The frequent surgical procedures that the patient they need, and the frequent use of antibiotics, which put them at risk of having multiple drug resistance or maybe developing a new strains difficult to control. Then we'll go to the nutrition, which is a major vital thing to control and to help the conjoined twin. So the conjoined twin will require very careful individualized nutritional assessment post-separation that usually it will be focusing between the interaction between the metabolic rate, the nutrition uptake, and in special circumstances. For example, comorbidities is a very major thing. If the child, they have any cardiac, renal issues, so we need to adjust the fluid intake for them. Wounds also, the metabolic rate, as we know in the wounds, it will be increased, so we need to adjust even the requirement and the calories, even also from the infections. And most of the time, we receive a call from our colleague from surgical. They said, please optimize the nutrition so we can help in the wound healing. So most of the time, the practice in our nutrition that they use the maximum protein intake, which is about the 3 grams per kg per day, which will help the wound healing. One of the factors also the cross-circulation. So we need to make sure that now after separation, the cross-circulation factor need to be adjusted. And even we need to make a consideration to adjusted weight for amputated limb. In our patients, they are shared in the SQ-PEGs. They choose between oral versus enteral versus TPN. So most of our conjoined twin, alhamdulillah, they are being tolerating orally, but sometimes some of them, they might need some enteral feeding. TPN usually is almost always needed as a temporary during hospital. One of like the interesting observation we have been seeing in our practice is the oral aversion. So it's well documented in the conjoined twin in the literature before the separation, giving the position, giving the anatomy, giving the reflux, but we have been seeing post-separation the oral aversion happening. Although most of them, they have normal feeding, swallowing before, and even if we did all the evaluation after, they have normal. So it might be like a behavioral thing. We made our observation, but it's really kind of a challenging for post-separation care to transition them back to home. We're still keeping our observation about this special. So this is just a quick thing to show you about the detailed nutritional assessment is being done by our nutrition in hospital. So it's really thoroughly following everything from pre-separation, post-separation, and you can see the difference from before and after. This is another example too for both twins in a different type. In terms of development, most of the survivors of conjoined twin are developmentally appropriate to age. The long-term survival and outcome in relation to education and social outcome in separated twins, they are very good. Really, they are very socially interactive. I think for the prolonged hospital stay with us, they are very active and interacting. But again, need to keep in mind that it depends on the type and the complexity of the conjoined twin. Some of them, they might need some intervention later on in terms of like a speech, audiologies, or some mental health assessment. In the term of the psychosocial, which is a major thing, I think it's for the whole journey from pre-separation, separation, and post-separation, it's a multifactorial. There are a lot of factors that can contribute to their psychosocial health. For families, for the twin, for the siblings, and everyone. So one of the major things is the relocation. As we have seen and heard from us and our colleagues from different countries, that most of the conjoined twins and their family, they are relocated from their home. So they are coming from different city to city or from different country to country. So imagine to have like a conjoined twin after separation, you need to deal with them and you lost the extended family support. Language and culture also play a role. Having a single parent would have been experienced in our institution. It's really difficult to handle both twins post-separation and the financial constraint for sure because they are coming and staying, for example, for a long time. So most of them, they will be needing a financial support. Some of them, they already lost their job in back home country. Privacy, it's a huge thing because most of the time they are spending in hospital, we are here and there, everyone coming back and forth. So the privacy is it's not that much provided for them. So in the literature review, they mentioned that the severity of anatomical compromise at birth, it's not necessarily correlated to the significant psychosocial adjustment. Proactively recognizing and addressing the psychosocial effect, it will be a very huge thing to address it and improve the experience and the long-term outcome. So in particular, if I want to talk about the psychosocial in terms of the twins themselves and the siblings, they will be experiencing the adjustment, which is a huge thing. Because of the transition from a shared existence to individual life, it can be emotionally challenging for both of them and for their families. Siblings by themselves also, can be affected because they are here with their family, they are here with their siblings, most of the time in hospitals. So they are like losing the social interactive outside. Some of them, they are missing the schools. Although in our hospital, we are trying, if a sibling came with them, we enroll them in school so they need to catch up with that performance. Lastly, the parents and the caregivers, which they hugely impact on them because they are the care providers, they are the decision making. The prolonged admission by itself, it can cause a depression, homesickness, and extended family members who are not there with them to comfort them. Also the guilt and anxiety when making decisions. So they need huge mental health support and also the support group. If they have another family or another children with the same condition, it will help. And I think this is luckily we have it in our institution because we can host sometimes more than one conjoined twins, so they can talk to each other, they can support each other. So they have by nature support group coming as a whole in a package. We are also lucky in our institution for this year, we're starting the Child Life Specialist Program, which can be hugely helping the family, the twins, and the siblings. And inshallah, will be maybe by next year, we can provide you more of information about it and how it's helping the separation and post-separation care. So then we'll go to the rehabilitation, which is the major thing as a post-separation. So the rehabilitation is started post-separation, again, inpatient with a very focused goal with early intervention, and then we do the outpatient rehabilitation service. As you can see from the first picture, our patient, she was very eager for the post-separation to move on. So the goal of the post-separation rehabilitation is therapeutic positioning, so to promote the wound healing and the corrective positioning, the range of motion, so we can address if there is any pain, if there is any spasticity, any stiffness, any contracture, to restore the motion and the function, balance and coordination, which is a really huge thing in some of our patients because they need to relearn again that they are walking only for one and not for two. Adaptive equipment that sometimes it needs to be customized given their age and weight, and the prosthesis and orthotics. This is the challenges in rehabilitation we have been experienced and been shared with our amazing physiotherapist in our team in a complex care, and I'd like to thank her, Ms. Rasha, for the conjoined twin that they are being experiencing at the post-separation. They have been noticing that the challenges they have because of the complex anatomy and anomalies. Each case of the conjoined twin is unique, so they need to tailor each rehabilitation plan for them. They need to require high personalized therapy plans. Immobilization in craniopagus twins before the cranioplasty because it's really having a high impact about the safety if they fall or anything. And also the multiple anomalies in ischiopagus twins around the hip affect the function and the sitting and the standing position. Also the muscle atrophy because of the prolonged immobility due to medical precautions and anatomical barriers. So after that, we'll be starting the discharge planning. So once we have the patient medically, they are stable and we receive all the clearance from all the amazing specialties has been in their care. As a pediatrician, we need to update their vaccines. We started to develop their own routine daily activities, provide them with a medication schedule if they are on, and to have the equipment available and ready for them. And one of the things that we have been experienced, it is the transient to home. So as we said before, that most of our conjoined twin, they are coming from different countries. So when we are going to send them home before the real home, usually they go to a residential facility, which is being supported by our social team and the institution, which is just across from the hospital. So it gives the conjoined twins and the families kind of confident to deal with them before going finally back to home. So they feel that they are close to the hospital and they feel that they are already at home. Sometimes we need to involve the home health care if they need like more of like some adjustment or monitoring at home in terms of weight and some of like wound care. Travel and seating, it's a very important. We need to assess before sending them home because as we know, some of them, they have difficulty in positioning. We need to make sure if they're going by plane or by car, so they need to have this plan. We provide them with a detailed medical report for their own institution and the follow-up later on. So the outpatient care and a follow-up, so it will be mainly medical teams, surgical teams, and allied health and rehabilitation. Initially, it will be regular follow-up. Most of our surgical teams, they prefer to have a 4 to 6 weeks follow-up post-discharge. Then it will be spaced every quarterly, then every twice per year, and then it will be annually based on the condition of the children. So the long-term outcome for them, it's as we mentioned, it's each case is a unique, and the outcome is depending heavily on the circumstances that the surrounding the twins' condition and the separation process. Almost always all the long-term studies of the separated conjoined twin have shown that while some of them they thrive and do well, some of them they face some challenges. For this slide, I would just want to echo what has been mentioned yesterday about the need and the collaboration, and to make sure that most of the conjoined twins post-separation, they ensure the accessibility and the access to health care for the post-separation care, because most of them, they need reconstructive surgeries. They need equipment, which will make the quality of life for them and their family better and huge. Also, as I've been mentioned yesterday from His Excellency Dr. Rabia, that the research is very important. In our team, we're starting to do some of the work and learning from our experiences. So multiple nutrition protocol, rehabilitation protocol, and long-term outcome will be addressed. So in summary, the multidisciplinary team approach, as we mentioned, held thoroughly through this conference, and the careful planning, the advanced technology, and the separation of the conjoined twin can be done with a favorable outcome. The journey of the conjoined twin by itself, separation, is a very complex and need careful medical, psychosocial, and social support to improve their chances to live a fulfilling life. Finally, the conjoined twin journey is a continuous learning process for everyone. And finally, and lastly, I would like to thank all the families from the conjoined twin for all the work that have been done. We know that your journey is complex and difficult and hard, and we are here for you. Thank you for choosing us. Thank you for letting us in your memories as you are in our memories. And thanks for all healthcare providers.
Thank you, Dr. Al-Nouri. That was a very, very comprehensive review. And next, we'll have Mrs. Dora Al-Sadoun, our social worker, talking to us about social care and support to the families. I always say that I cannot function in my ICU without a social worker.
Hi, hello everyone. Bismillah ar-Rahman ar-Rahim. I'm Dora Sadoun. I would like to thank King Salman Center to give me this chance to be a part from the success story. I will talk about the social care and support for the family. The role of the social worker in the hospital environment, especially when dealing with the conjoined twins and their families, is important to provide comprehensive support. These challenges can be emotional, logistical, social, and financial, making the social worker an indispensable part of the healthcare team. There are several sequential stages that begin before the twins' arrival to Saudi Arabia. Sorry, I'm not move this one. Yes. Okay. That's it. Pre-arrival stage. A meeting is held with the entire medical team, led by Dr. Abdullah Rabia, to discuss the twins' condition before arrival and to make full preparations. Okay. Conjoined twins arrival stage. My work as a social worker begins from the moment they arrive to the hospital, received and reassured, where a social assessment is conducted for the twins' families, and they are informed of their rights and the services provided to them. During their stay in the hospital, families of conjoined twins often face challenges, such as absorbing medical information, managing hospitalization, and dealing with the demands of caring for two children whose lives are interconnected. Continuous moral support for the twins families throughout their stay. During the twin stay, the birth of conjoined twins and their medical journey can be stressful for families. As a social worker, I provide emotional support to help parents and siblings deal with the uncertainty, stress, and grief that may arise. Help families process difficult decisions, such as surgical separation or palliative care. Facilitate individual or group counseling sessions for family members. Providing financial support and all they need, such as clothing, toys, trolleys, and sitter needs. Be present on the day of the separation surgery from early morning until the end of the surgery, checking in on them at all times and providing support and assistance to the conjoined twins families and meeting their needs. Standing by the conjoined twins families as Dr. Abdullah Rabia begins the countdown while they watch on the live screen is not only the emotional moment for them, but for everyone. Cultural sensitivity. One of the most important things that the social worker focused on and respect is the religious, cultural, and social background of the families and how it affects the medical decision taken. In addition to the language barrier, my experience working with the families of twins who do not speak Arabic or English was to seek the help of their country's embassy to provide a translator in medical meetings. As for the daily matters, during their stay in the hospital, I used instant translation applications, which made it easier for me to know their conditions and needs and provide it for them. Advocacy. So the advocacy is the cornerstone of the social worker role, as they advocate for the rights and needs of twins and their families both within and outside the healthcare system. Crisis intervention. Families often face moments of acute crisis, such as unexpected health complications. As a social worker, I provide immediate support in these situations by providing guidance during emergencies and helping families stay calm and focused. Facilitating communication with medical team during critical moments. Providing short-term coping strategies to manage emotional exhaustion. Discharge planning. Preparing for life after hospital stay in a critical part of the social worker role. Discharge planning involves ensuring that the families are equipped to care for the twins at National Guard guest house before they travel to their countries. Coordinate with outpatient services such as physical therapy or home health care. Provide families with contact information for ongoing support. The social worker's role extends beyond discharge, offering ongoing support to the family as they face new challenges. This includes facilitating long-term counseling, connecting families with peers who share similar experiences, and organizing mentorship opportunities or events. To promote, especially, social worker help families build stress management and problem-solving skills, provide resources for adapting the twins' evolving needs, and encourage open communication to strengthen family relationships. Finally, my role as a social worker is to provide full support to parents and their families before, during, and after the treatment plan, to ensure that families receive the comprehensive support they need to overcome cultural and social barrier. Thank you.
كونوا لها فبكم تكون بلد ثراها من نعيم قدر لكم أن تخلقون عظماء من بلد عظيم كونوا لها فبكم تكون بلد ثراها من نعيم قدر لكم أن تخلقون عظماء من بلد عظيم يا فخر العرب تاريخ ونسب والمعدن ذهب سعوديون يا عز عمره ما نضب سعوديون يا فخر العرب سعوديون تاريخ ونسب سعوديون إيه سعوديون يا عز عمره ما نضب أنتم كما الغيث الهتون بالبذل والجود المقيم خلقا به تتفردون فضل من الله الكريم أنتم كما الغيث الهتون بالبذل والجود المقيم خلقا به تتفردون فضل من الله الكريم يا برق الهمى مروين الظما والنظرة سما سعوديون دمها وياه وانتما سعوديون يا برق الهمى سعوديون سعوديون والنظرة سما سعوديون دمها وياه
Thank you all.
There is no way that we cannot get emotional about this, right? So this is incredible, and congratulations in the work that you do, Ms. Dora Al-Sadoun. So no ICU, no program can work without data, and we need data to actually direct what we do. So now we're going to hear from Dr. Majid Al-Fadel, who is the Deputy Executive Director and Director of Medical Genomic Lab at the King Abdullah International Medical Research Center on data banking and research. He's also Chairman of Genetics and Precision Medicine Department of the King Abdulaziz Medical City, Riyadh, and Professor of Pediatrics and Genetics, King Saud bin Abdulaziz University for Health Science. Welcome.
Thank you so much for inviting me to this humanitarian program. Actually, all of us now, we have an emotional moment after this video. So we will start with the definition of data banking. So data banking is a centralized storage of structured and unstructured data for analysis and sharing. Like genomic data banking, clinical trial repositories, business intelligence database, and research is the systemic investigation to establish these facts or principles. So research will enable access to extensive data set for robust analysis. The importance of data banking is self-explanatory, and it facilitates large-scale data analysis, encourage collaboration across disciplines, promote data transparency and reproducibility, and it drives innovation through access to diverse data sets. And the types include healthcare data banks like genomic data, electronic medical record, environmental data bank like climate record, and financial data bank, and finally academic data bank. The healthcare data bank usually categorized into phenotypic or clinical data bank like health record or lab result or medication histories. Research data bank like what you see in clinicaltrials.gov, and public health data bank where we collect and analyze data for public health monitoring and disease prevention like CDC and WHO, and pharmaceutical data bank where FDA database, genomic data bank, and finally health registries. Challenges in data bank, first is data privacy and security. The risk of misuse is obvious. Data sharing policy usually lacking between even the center inside the countries. Data standardization where diverse format and protocol, ethical concern, and I think there is a session about ethical issues, and cost and infrastructure. It costs high cost for storage and maintenance. And I remember when we did the whole genome sequencing in Kmark, we consume, with 100 genome sequencing, we consume around a third of the National Guard health data bank registry. What is the application of data bank in research? It's also self-explanatory, healthcare, environment, and business and technology. And I will go with this case study about a human genome project. And this illustrates the importance of data bank in all the humanity. So in 2003, these three gentlemen actually won the Nobel Prize. Why they won the Nobel Prize? You know, each individual has different gene changes than the others. So always we have our normal genetic changes, and also we have abnormal genetic changes where we cause the disease. So to differentiate between pathogenic and benign changes in DNA, you need a robust data bank for the whole genome of the humans. So these three scientists came with this idea that we will collect all the genome of the whole population and see the infrastructure for the genome database in 2003 to differentiate between the benign changes, or polymorphism we call it, and pathogenic changes. And 6 countries were participate in this important project, which is USA, UK, Germany, Japan, China, and France. And this was in 2003. And all the genomic database currently exist based on their work. So currently we are differentiating between pathogenic and benign based on this work. So as you can see, no Middle East genomic data in this project. So we need to have more work in our databases in order to differentiate between our benign changes and our pathogenic changes. So the study design that use data banking include retrospective case control studies, retrospective cohort studies, historical clinical trial, and of course to make it accurate, you need to validate the data, completeness of the data, and easy access for the data. And the best site for healthcare data bank is a research center, specifically biobank, where exists currently in King Abdullah International Medical Research Center. The King Abdullah International Medical Research Center has the largest biobank in the Middle East. KMARC, or King Abdullah International Medical Research Center, has multiple sites around Saudi Arabia, including Riyadh and Jeddah and Al-Ahsa. And its biobank is targeting 200,000 individual and disease subject for a fluid and solid body tissue sample, while DNA RNA reservoir capacity is around 2 million tubes for genetic diseases. So what we are doing currently with data banking for conjoined twin, actually it's all reserved or registered in health medical record, but also we started a project in 2019 for genomic data banking of conjoined twin, and it is approved by IRB in King Abdullah International Medical Research Center. And to understand this project, we should understand the cell. So the cell, all of us formed from one cell, and this cell is divided into 2, then 4, and 6, until trillions of cells in our body. This cell contains the nucleus, and inside the nucleus we have the chromosome. And inside the chromosome we have the genes, and the genes is the encoded by DNA and responsible about each function in our human, so on our body. So based on that, we divided the genetic abnormality into 3 major categories clinically. So the first category is single gene disorder, where there is a pure genetic changes that causing the disease. For example, sickle cell anemia or thalassemia. So HBB gene is responsible about the abnormality or the disease. While, for example, the other category, chromosomal abnormality, where the problem in the chromosome, like trisomy 21 or Down syndrome, where the 2 chromosome or 2 set of chromosome or 2 copy will become 3 at a chromosome 21. And then finally, the complex genetic disorder. And this is the most challenging part when we become to the genetic, which is the interaction between environment and the gene. And the most of the diseases we have currently is a complex, like diabetes, hypertension, juvenile idiopathic arthritis, rheumatoid arthritis, congenital heart disease. All these are complex genetic disorder, and conjoined twin is part of this category. So because of that, interpretation of genomic data for conjoined twin will be so challenging, and we need to accumulate more data banking of this genomic data in order to find a genetic abnormality that we can robustly interpret. So the objective of the project to data banking of genomic data for conjoined twin, we do whole genome sequencing for all conjoined twin samples to identify the potential novel variant or candidate gene. Then we do functional and expression studies such as messenger RNA, real-time PCR, Western blot, and also we collect fibroblast culture in order to apply this functional study. And this will help to establishment of genotype-phenotype correlation between the disease phenotype and identified candidate gene. Currently, we collect around 11 pairs from Saudi Arabia, Yemen, Sudan, Libya, Iraq, Mauritania, Morocco, Algeria, and Italy. And we did the whole genome sequencing for all of these pairs, and we hope we will correlate it with the clinical phenotyping and try to interpret these challenging data. In conclusion, data banking is important in understanding and conducting research. Data banking will help in innovation and answering a question that cannot be answered without data banking. Type of healthcare data include clinical, research, public health, pharmaceutical, genomic and health registries. Data sharing policy is one of the important challenges for data banking and research, and genomic data banking for conjoined twins are important project running currently in Kmart. Thank you so much.
Thank you, Dr. Fadel. This was incredible work that you guys are starting, and this will bring a lot of fruits in the future. Going back to the bedside for a little bit, now we're going to hear from who actually runs the show in the ICU and in many areas of the hospital, nursing staff. So Mrs. Iris, Pediatrics, King Abdullah Specialized Children's Hospital. Thank you. She's going to talk to us about nursing care of conjoined twins. Welcome.
Good afternoon, everybody, and Masa al-Khair. It's really indeed a privilege to find ourselves standing here, and it's really an honor. I want to thank the families of the conjoined twins to allow us to nurse their patients the way we do. Thank you all. Whatever I'm going to discuss today, I think it's just a smidgen of what we do as nurses, because we really have a short time to discuss this. United yet unique, and exploring uncharted path in holistic nursing care for conjoined twins. Thank you. Disclaimer, we're just using photos that we receive consent from. Conjoined twins are a rare occurrence, as we know. I won't discuss how it is formed, but their care requires specialized nursing to manage their shared organs, monitor and support growth and development. In this case, nurses play a pivotal role or a vital role in providing high reliable safe care, coordinating multidisciplinary care, and preparing families for surgical separation and long-term care. Definitions, I won't go through this because most of the physicians have been explaining the same information and over again. So I'll just say to our nurses, it's very important that we understand the anatomy and pathophysiology of conjoined twins for better nursing outcomes. Okay, this is a road, the pathway from pre-access to care until we discharge the patients. And really, we know that this doesn't end in discharge because they have to have lots and lots of follow-up, as Dr. Nouri has explained before. Pre-arrival preparations. In our hospital, we have dedicated units for admission of conjoined twins, meaning that we have our surgical ward, we have our PICU, depending to the condition of the patients. They might start in HDU, or they might start in PICU, or post-op, they go to PICU, or they might go straight back to our surgical ward. Pre-admission notification, we work with our public relations who will give us information about when the twins will be arriving. Then the show begins. A detailed medical report, including vaccination records, will be sent to the unit, and also the medical imaging. Sorry. Staffing resource, we prefer primary nursing model of care. Why? We have to handpick special nurses who will take care of these patients. Even though we might have junior nurses who are still new, we'll make sure that we have preceptors who will follow up on them. So why do we need primary model of care? Because this is the only model of care which allows continuity of care. We need the same team to focus on the care and to be able to identify the subtle changes from the different twins that we have. Nursing teams of experienced staff from the ward, OR, and PICU are nominated for each set of twins, and their names are submitted. Then we come to staff preparation. The moment we know we are going to receive maybe craniopagus twin, then the teams start preparation. In the ward, they will discuss a case together with all the nurses who will be involved in their care. Educational sessions will continue by the CRNs. In PICU, they will even start to have simulation. Lucky for us, we have PediStep simulation, where we can simulate everything that will go through. Sometimes we simulate the emergency like mock code blue, so that we are ready. Admission and initial assessment. Let's start with communication. We are aware now that our twins are coming from different areas, as illustrated in the map. However, who wants to come in an area where you won't be able to be communicated to because of the difference of how you look like, your religion, your language, and your different culture? Of course, when they arrive, we need to be able to communicate with them. Our public relations, again, will arrange that we have translators by our side. By the way, Dr. Nuri will agree with me that our hospital is our home and our patients are our guests, right? So if they're our guests, we need to communicate with them. Let's start with a patient identification process, which everyone who presented really, they stress more on color coding, even though we know that the main thing is MRN and medical record number and full name of the patient. We also include color coding of our patient. Based on medical assessment, the healthier twin will be color coded orange to reddish color, and the second twin will be color coded blue. The same if they're both healthy, the bigger one will be color coded orange, and the smaller one will be blue. You can see here in the picture, measuring length and height and weight. Why must we stress this? Our nurses know, they are pediatric nurses, they know growth and development better than even me. They know that it's very much important to monitor growth and development. Why? With the twins, there is a way of doing it. For example, you are monitoring the length, you have to follow the limb that is next to the conjoined twins that you are measuring the height until the foot sole. As far as working weight is concerned, we get the combined weight and divide it by 2. All right, I cannot stress enough here. We really have to do assessment, reassessment continuously. Pediatric nurses use all their senses to make sure that we identify any issue that is relevant and escalate immediately. Let's start with vital signs. Dr. Sherry has already mentioned that sometimes one twin will be hypo, one twin will be hyper, I mean in case of blood pressure, sometimes bradycardic, sometimes the other twin will be tachycardic. So, when we monitor their vital signs, alhamdulillah, in our hospital we even have guidelines of PUs. We have to trend their vital signs so that we understand their trends. Activity levels, again, we have our dedicated team of rehab who help us to exercise and to identify any difference in range of motion. Sometimes you find that this twin is very active or hyperactive. Even though the other twin is sleeping, the other one is pulling the other one away. Again, growth and development. We have play therapists who will assist us. Now, as Dr. Nouri mentioned, now we have child life specialists also who are part of the team. We have psychologists, the whole package to make sure that our kids have benefits to grow the way they're supposed to, like any other child, because this is their right. Nutritional status. Guys, I have experienced that most of the twins who are the ones who are taking more look smaller, and yet the bigger ones, they stay there, they eat only a few, then they become bigger, while the smaller ones remain the ones who are taking a lot of milk or any type of food they might be taking. Output. Oh my God, with output, Dr. Shamar is looking at me right now. He even complained earlier that you are forgetting the urology part of it. So with output and Dr. Jadaan sitting there, bowel motion and urine, we have to check where does it come from this twin or from the other twin. So if we put diaper, we have to measure and check, we trace where the urine or the bowel is from. You might find that one of the twin is having pasty stool while the other one is passing normal stools. So this is important to be documented and discussed with the surgical team. Medication. Dr. Sherry also explained earlier that when we give medication, sometimes you give medication and the effects goes to other twin. So what do you do in that case? Observe and assess and reassess and give thorough information to the medical team so that they can then plan. Pre-surgical planning. What do we do? A lot of diagnostics and investigations. Radiology work with us, laboratory investigation, and sedation precaution. You can see the picture that I put on the side. This is the picture from our child life specialist trying to assist and simulate all the procedures like MRI so that the patients will feel better and the parents will feel comfortable that their patients will be safe. As far as the procedures are concerned, some of the patients might even be intubated in PICU pre-op. PICU is also having the policy and protocols to follow when transporting the patients for medical imaging to make sure that our patients are safe. Sedation precaution pretty much is, you might sedate both, then you realize that only one is sleeping. The other one is awake and is pulling the other one left and right. So you cannot even control it. Multidisciplinary meeting have been mentioned several times. We are lucky here. We have complex care team, which is multidisciplinary. And we also have the multidisciplinary meeting, which is held and led by Dr. Rabia before the separation. So we are part of these meetings. Day of separation, I just want to say thank you, and thank you again to our lovely teams, our nursing team from OR, our nursing team from the ward, our nursing team from PICU, because on that day they all sit and wait and make sure that the twin comes back, even though they are coming at 1 a.m. in the morning. You will find nurse managers of PICU there stabilizing the patients together with their team. Alhamdulillah, I feel I'm blessed to have a team like that. Transportation to operation rooms, I'm just giving you a picture here, where it is very difficult sometimes. When we're transporting them, we have media services, we have everyone who wants to see, but we try our best to make sure that the patient's confidentiality is well maintained. Patient handover in holding. Why must I talk about handover in holding? Maybe Dr. Saad will tell me why, and Dr. Zugebi. Because we want one nurse to hand over one patient. Not one nurse handing over both, because we might have mistakes. We want to ensure that our patients are safe. Time out. I'm in OR now. However, I just want to stress the color coding system here only. Why? All the cables are color-coded, the pumps are color-coded, everything is color-coded inside OR also. And then from there, we know that we have to prepare PICU. We have dedicated room with 2 cardiac monitors that are conjoined to each other. You will see the picture very soon. Post-surgical care, specialized management. Dr. Sugebi was talking about acute pain management. This is his baby, I think, Paps. And we are so happy to have a team of Dr. Sugebi, Dr. Saad, who is helping us to keep our patient calm, thereby making sure that the wounds heal faster. We have patients who might be on continuous renal replacement therapy. This might even happen intra-op. So what do? We send our nurses down to OR a day before to prepare everything for the patients. Then they will be part of the team during the separation. When they come back, even though sometimes before OR, you might find that we have patients with EVDs. I'm talking about craniopagus here. You find one is having EVD and one doesn't have EVD or lumbar drain. How do you level EVD when they're still connected? How do you do that? How do you make sure that you don't have excessive CSF fluid coming down if the other one will move the other one in a different direction? I might say the skilled nurses of a surgical ward under Ms. Amani, they know how to do it better. Whether we have 3 EVDs inserted, whether it's 2 EVD, alhamdulillah, we know we'll be safe. Wound and osteomy care, they spoke about mesh, they spoke about very big wounds. Sometimes you don't even know where to attach the ileostomy bag because you have to measure everything that comes out, isn't it? I remember when I was still a new nurse in one of the units in the main hospital, I asked Dr. Shamari, oh, you did this nice procedure. Then tell me, all these 5 tubes, where do they come from? And how must I monitor them? Which one I must expect to have urine while the other one must have no urine? They stand there and make a drawing and show me everything, how it works. Then from there, I continue to teach my nurses. If the urine is coming from here, we must be worried, then we must report. If the urine is not coming from this tube, we must be worried. Please report. And at the same time, if any tube comes out, ladies and gentlemen, and is surgically inserted, it becomes a big issue with us. We have to investigate, why did the tube come out? Let's look at our practices. Can we prevent this? The team of Amani will agree with me that we are even having KPI to monitor all surgical inserted tubes, because we don't want them to come out. We don't want the child to go back to OR and to go through anesthesia again. Mechanical ventilation, Dr. Sherry explained it thoroughly, as it's his specialty really. We sometimes keep patients on high frequency oscillator, multiple inotropic support. Again, you give inotropes because the BP is low, then another twin becomes hypertensive. So what do you do in that case? Management of separation anxiety, I cannot stress this enough. When the twins come, whether they are conjoined or they're separated, they want to be able to connect with each other. In one of the units, especially with craniopegas again, when you switch on TV, you put a mirror in front so that the other twin will be able to watch whatever the other twin is watching. So this is what we do to make sure that they feel safe. I remember after separation, we had one twin who was refusing totally to eat. Nothing, they refused until we keep them together in the same room next to each other. Sometimes we put them in the same bed. Then they started feeding each other. Guys, that is lovely to see. Then we become very excited and happy. Body image changes will continue for a long time. And Dr. Nouri mentioned that, as we know, the patients will stay in our hospital and sometimes in our residential area. We have people who will work with them, our psychologist, our child life specialist. Alhamdulillah, we are lucky about this team being embedded in the multidisciplinary team. Thank you for the leadership, who is always thinking to make sure that our pediatric patients are safe and they are well loved, because they deserve it all. Sorry, let me go back and show you our PICU room with 2 monitors. I think you can see that clearly, huh? So once they are pre-separation, we can keep them in that room. We have 2 rooms like that. One in another PICU and one in another PICU. We have medical PICU, we also have surgical PICU. Pre-op, they might go to medical PICU, and post-op, they go to surgical PICU. Recovery and rehabilitation, I won't say much about it. Dr. Nouri has explained thoroughly. Looking at this picture of these conjoined twins, we might think that this is the only time when we transfer them to the ward. No, not at all. Like what Dr. Sherry said and mentioned, that in PICU, the estimated length of stay is 2 weeks. Do I remember correctly, Dr. Sherry? Yes, most of them. So, if it is only 2 weeks, remember, they might go to the unit, back to the ward with all the tubes that we speak about, sometimes even 5, sometimes 6 colostomy bags, ileostomy bags, and they really have to monitor them in the ward. So people must know that our ward is really highly specialized. Challenges. Due to their position and their anatomy structure, we have difficulties in the airway, but we have something called DAT in our hospital, started by anesthesia. Alhamdulillah, we even have a policy where we can just call them anytime to assist. Anatomical challenges like IV insertions. As nurses, we are good in IV insertion, but sometimes these twins are challenging. And catheterization, when we fail, Dr. Faiz and Dr. Shamari step in. Maintenance of skin integrity, we also have our work team who works with us. Remember, sometimes you have mesh, you have a very raw skin this side, you still have to attach a bag here, you have to take care of the patient, you need to check every gauze that comes out, you measure the weight, you measure each drop, as it has been mentioned before, because we have to replace everything that comes out. Care of the surgical wound, I've just mentioned. High risk of surgical site infection. This is a big challenge. We have leaks sometimes. We have big wounds that we cannot manage. Sometimes the wounds are next to the colostomy bag that might be leaking to the clean wound. So this is a challenge. But alhamdulillah, our nurses are well trained. They know what to do. They don't get tired of changing everything frequently so that we don't end up with infections. CLABSI, all this SSI, CLABSI, whether it's VAP, we have good bundles that we follow through our infection control to help us minimize CLABSI and SSI. Discharge process.
1 more minute.
I'm almost done. Discharge process, medical team, collaboration with other subspecialties, home health care, referral if needed, identification of medical technologies required, and arrange with simulation lab. We have PediStep, our simulation lab. It's not only for medical team, guys. We also allow our parents to go there so that they get educated on how to take care of their patients in a controlled area. For example, patients with tracheostomy, and for BLS, in case if something happened while they arrive home. Case managers and social worker involvement, home supplies, discharge medication, education, transportation, and follow-up. From 1 to 2, yet forever united, holistic nursing care transforms shared life into unique journey. Before I step down, I want to say thank you to nursing leadership in National Guard. Thank you to nurse managers that I can even mention by their names. PICU, we have Zara, we have Siham, we have Alex, HDU, we have Vicky and Noura. And our surgical ward, we have Amani, OR, that is led by DCN Anka and her team. So thank you very much for your dedication to make a difference in our patients' lives. Thank you all.
So this has been a wonderful session, and I know we are very much advanced in time, right? So there is a special ceremony that we we want to honor everyone that participates on this round table. And I don't think we'll have time for discussions now. I think what we'll do is you can approach each one of the members of the panel as we leave and talk to them individually, ask questions, because we still have another session to go at this moment. But I want to thank you, every one of you, for wonderful participation and every single aspect here of the care of the patient in the ICU and away from the ICU, going home, and even getting data from them for future research we all cover. So thank you very much for each one's participation. And now we have a little ceremony here, so we're waiting for somebody to come. Okay, so maybe while we wait, if anybody has an urgent question that wants to ask the panel, feel free while we wait for the ceremony to start. There's a question right in front. I can give you the microphone here.
Thank you very much. I enjoyed all your presentations, and it was an eye-opener to see what happens behind the scenes with patients and their parents. I have a quick question for Dr. Prof. Majid Al-Fadl. In your scope of research, is there any role future-wise for prevention of conjoined twins with the genome studies that you're doing?
Yeah, this is an excellent question. Thank you for that. I think this is just a start, and this is a unique phenomena. All science are virgin with this phenomena. So starting with data banking, it's a first step forward, and I am hope with the future, with more of cases and more of data and international collaboration and national collaboration, we can find something like this.
Thank you. All right, so ready to go? Please.
Thank you very much for a very insightful session. We would like to honor our guests today. Dr. Jaber Al-Anizi, Professor Daniel Garris, Dr. Esther Segiel, Dr. Ali Shahri, Dr. Ahmed Al-Saad, Dr. Asir Al-Nouri, Mrs. Dora Al-Sadoun, Dr. Majid Al-Fadl, and Ms. Iris Murevi.
boleh dikatakan hampir setiap hari hampir setiap hari kita bergaduh disebabkan berbeza haluan, dan sekarang ni mungkin lagi senang kot sebab kita dah berpisah kan. Lagipun macam kita orang berdua boleh jangkakan apa yang macam saya ataupun Muhammad akan cakap. So bagi pendapat saya, selalunya Ahmad dapat tangkap apa yang saya nak bagi tahu. So macam selalunya kalau kadang saya lupa ayat tu, Ahmad yang akan tolong jawab lah.
In nearly every aspect, they are in perfect lockstep. You might even say inseparable. Although 22 years ago, Ahmed and Mohammed actually were inseparable. Until the Saudi leaderships saw a televised British charity appeal on their behalf.
Sebab apa setahu kalau untuk Siamese twin, bila kita nak operation, dia menggunakan apa jumlah kewangan yang banyak. Kita tak mampu. So bila dia orang telefon untuk sponsor pembelanjaan untuk operation, kita alhamdulillah kira macam bersyukur lah.
After the charity received a call from the Saudi embassy in London about the Saudi leadership's offer, the twins and their parents were immediately flown to Riyadh. The twins, joined at the chest, abdomen, and pelvis, sharing a liver, colon, and a small intestine, had their 23-hour successful procedure at King Abdulaziz Medical City Hospital. Saudi surgeons were able to use skin from an unused third leg to cover the wound left by surgery, leaving each twin with only one leg. Twins were then fitted with prosthetic legs.
Kita rasa macam sebab Saudi punya doktor memang dia orang memang boleh buat. So memang orang kata alhamdulillah, memang banggalah. Sebab sebelum operation dia melekat. So dah operation dia asing. So kita memang rasa gembira.
After the operation, the twins were replaced in the intensive care unit for about a week, followed by months of physiotherapy and other necessary treatments at the hospital.
Kita operation masa 4 tahun kan. Jadinya 4 tahun tu dah tahu dah, maksudnya kita orang akan berpisah. Tapi sejak dari dululah kita orang memang nak berpisah. Jadi benda tu tak jadi satu masalah untuk kita kan. So macam saya, macam kita orang dah tahu dah pada tarikh sekian-sekian kita orang akan buat operation. So parents pun, mak ayah dah beritahu yang okey, hari ini kami berdua akan operation. So lepas operation ni lagi senang nak bergerak ke, maksudnya boleh buat haluan masing-masing.
On the 31st of December 1990, a carefully selected medical team, led by Dr. Abdullah Al-Rabia, performed the first ever conjoined twin separation operation in the Kingdom of Saudi Arabia. The operation spearheaded the kingdom's Conjoined Twins program, which has seen 60 sets of twins successfully separated from countries across the world, allowing them a chance to a healthy, normal, and an independent life. The Malaysian twins were the 6th set of twins in a remarkable 3 decades of separating conjoined twins, making the kingdom a world leader in one of the most complex surgical procedures in modern medicine. Under the Saudi Conjoined Twins program, conjoined twins arrived in Riyadh, Saudi Arabia,
filled with hopes for a brighter future. They departed the kingdom's capital, stepping into a new chapter of their lives, ready to embrace their individual journeys and the endless possibilities that awaited them. Ahmed and Mohammed have crafted their own paths in life, making choices that range from the small, everyday decisions to selecting their career paths and pursuing their hobbies with passion.
Ni tak dapat nak bayangkan macam mana hidup sebelum kalau tak berpisah. Sebab kami pun dah terbiasa macam ni, jadi kita tak terfikir macam kalau kita orang tak berpisah, macam mana kehidupan kita orang.
The Saudi Conjoined Twins program offered Ahmed and Mohammed the freedom to carve their own paths, and so with determination, courage, and the support of a dedicated Saudi medical team, anything is possible.
Itu saja. Terima kasih.
We hope you enjoyed the video of the trip with the Malaysian twins. And now, ladies and gentlemen, we delve into topics from embryology and imaging to 3D reconstruction and ethics. Moderating this session will be Dr. Hisham Al-Sha'lan and Mr. Chris Rockenbach.
Assalamu alaikum. It's been a great pleasure to have been here over the last 2 days, and I welcome all of our distinguished guests, eminent clinicians, ladies and gentlemen, for what is now the final session of the scientific programme. I think it's the vision of His Excellency that has brought us all together today and what enabled the beginning of the Saudi Conjoined Twin programme over 30 years ago. And therefore it is my pleasure to introduce our first speaker today, Professor Oluyinka Olatoye, Surgeon-in-Chief of the Nationwide Children's Hospital, the United States of America.
Assalamu alaikum. Well, thank you very much. It's a privilege and honor to be here, and I'd like to thank the organizing committee for the opportunity of being invited to be part of this excellent program, and really we've had a splendid time here over the last day and a half. So this is my second time to the kingdom, and this is actually a picture taken back in June of 2007, when I had the privilege then to come and visit Dr. Rabia because of my interest in conjoined twins and some of those that we had separated. And it's really phenomenal to see how the program has grown from that time. This is one of the initial pictures then of the twins that had been separated, and to see now about 60 pairs of twins have been separated since then. So it's truly an honor to be here to witness the growth and the expertise and really what has transpired with this program over the years, and you're all to be lauded and applauded for the great strides that have been done in this field, and how the Kingdom of Saudi Arabia is truly a world leader in the separation of conjoined twins, and really worthy to be celebrated for this great accomplishment. So I bring you greetings from Nationwide Children's Hospital in Columbus, Ohio, where I have been. Prior to that, I was in Texas, and before that at Children's Hospital of Philadelphia, where my combined experience with conjoined twins have been. But over the next few minutes or so, I hope to talk to you briefly about just a brief review of the embryology of conjoined twins. I will highlight some of the key imaging findings on MRI, both fetal and postnatal. That will be helpful, and maybe just a couple of cases to talk about how you can use this for practical considerations in the care of these twins. I have no relevant financial disclosures to disclose, but permission to use these images were obtained from families, and also we'll be discussing some innovative practices and images and videos from prior institutions. So I know a lot has been said about the embryology, but I just wanted to highlight a couple of things that are important here. Oh, thank you. Just highlight a couple of things that are important here that will be helpful too. As you all know, twins are not uncommon, but monozygotic twins on the left side are what's really different, as opposed to dizygotic twins with 2 eggs fertilized by 2 sperms. In monozygotic, there's 1 egg fertilized by 1 sperm. And you can either have the fertilized zygote can either divide very soon. If it divides within 72 hours of fertilization, you end up with 2 separate placentas, 2 separate amniotic sacs, 2 separate babies. And so there's again, they are diamniotic, dichorionic twins. If you go a step down, again, when it divides between 4 to 8 days, at that time, the placenta is already fused as one. So they share 1 placenta, but within that, you can have 2 amniotic sacs. So they're monochorionic, diamniotic. So they have 1 placenta they share, but 2 amniotic sacs. Now, if the division is after about 8 days, you can have a situation whereby they have 1 placenta, so monochorionic, 1 amniotic sac, so monoamniotic, and you have both fetuses within 1 sac, but 2 separate fetuses. Now, in the case of conjoined twins, that division or fusion is thought to occur much later, maybe after 14 days, in which case now you have on the final one at the bottom here, after 14 days, you have not only is there one placenta, 1 amniotic sac, the 2 fetuses in this case have not fully separated completely. And so that's where you end up with conjoined twins. At least that's the fission theory for conjoined twins. And so it's this unique apposition of these fetuses that allows the different configurations where they're still fused at the point of division will determine whether the fusion is at the head or the back or the buttocks, all the different classifications that we've talked about over the last day and a half, which again, for the sake of time, I will not go into because we've heard that over and over and over again. But none of this can be picked up early without opportunity for imaging and diagnosis. We've heard very early that without prenatal care, most of these twins may not even be picked up until at the time of a difficult delivery for the mother. So prenatal care is the first access point for which mothers have the opportunity to be evaluated, mostly by ultrasound, to even figure out that there's something going on with the baby. And we know that very early, even as early as the first trimester, ultrasound can help identify what's going on, or at least give a suspicion that you have 1 amniotic sac and 2 babies within that sac, or even maybe those babies are fused. But the unique thing actually is with advances now in fetal imaging, especially with fetal MRI, ultra-fast fetal MRI that can be accomplished without any sedation for the fetus at all. You can see in the left panel is actually some of the exquisite details you can see. That has nothing to do with conjoined twins, but you can see a fetus with significant mass within the neck that you can actually pick up on MRI and imaging and exquisite detail. But even more so, if you look at the image to the right, you can see that this is a multiple gestation. And just as I just described with you, you can see that there's 1 placental mass, so they're monochorionic. You can actually find an intervening membrane separating them, so they're diamniotic. But in this case, you can see 3 heads. So this is not just a set of twins alone, but you can see 1 twin here. In fact, this is a set of triplets, where you can see 1 triplet here, but this set, a set of conjoined twins. But even as early as 18 weeks, when this MRI was done, you can see that these twins share a common liver and a common cardiac mass. So already this early, you can make significant understanding and determination of to what to expect and how you can counsel these families prenatally. I know Dr. Rabia had spoken earlier yesterday about all the options that can come up in terms of prenatal diagnosis, whether there are things that can be done in counseling and if termination is an option, but really helping the family to understand what's going on early enough. So knowing that if these are those that may be amenable to separation, making the plans early enough to actually have these babies delivered at a place where the excellent medical team can be available and accessible to provide that care. So it allows for pre-planning that can occur way before birth. Additional things we can see, to even on those fetal MRIs, you realize that with growth and improvement, you can see changes over time. So you can see in the left panel is a set of conjoined twins. Again, you can see they look like they're thoracoomphalopagus conjoined twins. You can see the fused liver right in the middle. But as go over time, as they grow bigger, you can actually see more defined details. You can see already there you can start making out the two separate hepatobiliary systems, and it looks like the GI tracts are separate, the livers are fused. Within the cardiac area, you can see that even though there may be a position at the level of the chest, but there are two separate cardiac masses that you can see. And of course, on ultrasound, you can confirm an echocardiography. You can confirm whether these are indeed just shared in a pericardial sac or fused at all. So exquisite detail that we can see on fetal images. And I was going to just use this time again, not to go through what many people have spoken over and over, just use a few cases. Here's one, a series of sequences. You can see there that the areas you can see fusion at the level of the atrium, and also coming down, you can see there's a fused coronary sinus that we can see on sequences as you go through these fetuses at about 32 weeks. Again, same fetus in sagittal images here. You can see those different connections within the chest wall, within the abdomen, showing the different physiologic connections that will help you anticipate what's going on. When these babies are born, many of this information you can again confirm with CT angiography. This allows you now to get better definition of what the bony structures are like. And you can, in this case, we actually gave contrast, IV contrast to just one. So you can see the fetus on the right is having contrast enhancement, but you can see some blood going over to the fetus on the left, as you'll see, showing again that there's some cross-contamination or cross-perfusion of the other fetus. And you can see it here, that fetus on the right has the liver well perfused, but the remarkable thing here is there's a huge draining vein through the hepatic system draining into the contralateral twin. This is important information to know because this obviously would impact how you approach this, and I'll talk about this case in a few minutes. Here's another case to 29 weeks. Again, with this sequence, you can make out the different connections between the twins. As you're coming through, you can see the different livers, the different kidney systems. What was interesting in this particular twin, set of conjoined twins, is that on certain images on T1, you can see where the anatomy is. T1 is very good to see where meconium is, so you can actually look at the GI tract and already define what the extent of fusion and things would be. In this particular one too, we could find that we could, one single anus on ultrasound, you can identify the anal dimple, so you can even help define whether this is going to be one with a single anus or two anuses. And in addition, we saw that there was this interesting communicating vessel that you could pick up on ultrasound from one fetus to the other. And when you interrogate that vessel, you can see that it's an arterial flow, suggesting that there's an arterial connection in the abdominal vasculature, not the aorta, but something connecting the aorta of one fetus to the other, which actually appeared to be a branch at the celiac level, connecting one fetus to the other. Now, when those twins were born, again, on contrast imaging, you can confirm those things, and you can see here fusion at the level of the liver. The GI tract is there, doesn't appear completely fused. But if you actually look at the coronal images, you can again see quite pretty good anatomy, and that vessel that we picked up on fetal imaging, you can demonstrate crossing over the celiac level, combining, connecting one fetus to the other. So there's exquisite detail you can actually see even before birth with fetal imaging that can help confirm a lot of what to expect and anticipate. So a lot of the pre-planning has already happened. Now, the advantage of this fetal imaging is, as we just heard from many of the talks this morning and this afternoon, sedating these babies to go have imaging is not without its own morbidity. So actually being able to do this without needing to sedate them before birth and acquiring a lot of that information gives you a head start in terms of what you can anticipate and what you can expect. And so there are other things you can concentrate on that you can do in the fetal imaging that you just have to do after birth. Now, this was the set of twins I showed you earlier on that had a fused liver, a fused diaphragm, shared a pericardial sac with a large vein joining the hearts. You can see we can do three-dimensional imaging, 3D rendering of those. We can do we can make some 3D casts, or even do some image-guided 3D analysis as well. But what that allows you to do is actually see where the level of connection is. What I really liked about this particular set of twins was, you know that they typically have fused manubrium on either side that you can divide, but in the case of these twins, the manubriums were not properly fused and really were just off-center and off-kilter. I knew that it was going to be really a complex closure for the chest, and that allows you to plan that well ahead of time. In fact, when you separate out when you just separate out the cardiac structures alone, you can see how in this particular fetuses, the manubrium are off center of each other, and it makes a complex, you expect a complex closure for the chest. And if you actually look at it and put it in three-dimensional form, you can circle it around, and at the bottom of the heart, you'd actually see the pointer point at the bridging vein right up there. That's the bridging vein connecting one heart to the other through the coronary sinus. But the hearts were within one pericardial sac but not fused, so we knew there was still a chance we could separate them. But really the manubrium, as it comes over to the other side, you can see, again, those two manubria that are off kilter. So it's going to be some reconstruction in terms of how we separate the chest to be able to close those together. Now, these are those fetuses too, again, that we saw that had that abnormal vein. One thing we first noticed was that one fetus had a small hepatic vein on one side, and the hepatic vein of the other was very big. That was the first concerning sign. And when you gave contrast, you could see that there was the vessel going across from one fetus to the other. Now, what that means is if you're to divide this liver right off the bat, you're going to have significant hepatic congestion of one twin because it's relying on the outflow from the liver to the other one. And if you don't plan this ahead of time, you're going to have significant hepatic congestion, inability to close, and that can actually result in a lot of morbidity for that fetus. So what we actually did in this twins, in this particular ones, was to sequentially go in and actually obliterate that adjoining vein. So with interventional radiology, we put in plugs and actually occluded sequentially that bridging vein. Over time, that allowed blood to redirect back to the ipsilateral hepatic vein of that fetus to ensure now that that fetus will not be relying on that bridging vein at the time of separation. So we did one, we came back and did the other one, so you could be sure that now you've redirected the flow of blood away from that bridging vein to help the fetus, to help that baby on the left be able to be separated. And so you could think, again, we made molds of this. You can see the manubrium shows up nicely in the molds. The two liver masses are put in separate colors so you can understand the plane of separation. You can see all the different configurations in different models all around. And as we've talked about too, none of this, every case is different. And so getting the team together and actually having an in situ simulation. Simulation is good, tabletop simulation is good where you talk about the cases, but actually in situ simulation, and this is what we did as a group actually, we typically would do this on on a weekend where things are usually quiet, so everybody can come in, and we actually have it. We plan every step, all the step of the way what we're going to do. We actually make mannequins that we weigh them and make sure they're the appropriate weight for the children, so the feeling of what it's like is there. We wrap them up together in the appropriate configuration, so you're actually, again, mimicking what the babies are. We had the whole simulation filmed, so we can go back and rehearse what did we do well, what are the areas that we need to improve on, what are the opportunities. One of the complex parts of this too is how do we drape them, how do you prepare them, how do we prep them. You can see how the dummies are wrapped together. You may actually see some weights. We added some weights to the back of the dummies again to give them that feeling of the actual size of the babies. One of the most difficult parts of this procedure actually is the prepping, because we do a circumferential preparation. So actually having them held up and prepping them and all that, feeling what the weight will be like and what that's going to be, again, that's part of the simulation that you actually get to do to make sure that people go through this whole procedure and what's needed to go through. Again, we're there practicing what it will be like. How many people do you actually need to carry them up so you can do the total circumferential prep? Where the line's going to come from? What do you really need to do? What's that going to involve? And so all that is simulated and prepared and tested before you actually go through. And again, we have people who are not part of the medical team, who are mostly just simulation folks, looking at how does the team work, what are the areas, what are the questions, keeping a complete note of what needs to be done and what needs to be effective. And we come up with a huge checklist of all the things, all the points that we made, things that we need to make sure that we accomplish on the day of or before that need to be in place. So the fact that we're throwing ideas and coming up with stuff, you still want to make sure that on the day of, you don't forget all the good ideas you had during simulation. So someone is actually keeping records of all that so we can go through and pick up all the things that we need to get done on the day of surgery. And so, of course, all that leads to the final day of separation, where you go in and have the whole team going again. These kids had tissue expanders placed in. You can see the family gets to be part of that trip until the point of separation. And of course, the whole thing goes on for hours until you accomplish the final goal here, which is both babies separated side by side, and then they go on to their next phase where you put them on separate operating tables, again with the separate monitors, separate teams, and each color-coded team goes their separate ways to complete the closure for the kids. So again, it's usually a tour de force of what this involves and what this entails. But as we've talked about, this is all interesting stuff, and the future of this really is how can we improve what we do here? What's the next step? And what can we do? We've talked about fetal surgery a bit here today. And for those who don't know what fetal surgery is, I was just going to show a brief video here. The concept is all these things that we're doing after birth, can we do some of it before birth? But what does that really mean? So of course, with fetal surgery, it means you get to go into the abdomen, into the uterus, to be able to do surgery. And so here's just a quick picture of that. A laparotomy is done. You expose the uterus and identify where the placental membranes are, and really anchor the membranes to anchor the membranes to the myometrium, and then use a stapling device to open the uterus. In this case, this was not for conjoined twins, obviously, but just something to explain what's possible. In this case, this was the child with a huge chest mass that we were doing for large CPAM. But here now you can go into the uterus and actually, with the fetus in there, not totally brought out, you can expose just the part of the uterus that you need to bring out. And the goal is you can go into the chest, open up the chest and operate. So potentially, if this was abnormal connections within the heart that you need to dissect out, you could do that. If these are issues if this was just a thoracomphalophagus, that you need to do some of those disconnections before birth, you can. If this was even a parasitic twin that was dying in utero, you could potentially correct that in utero and preserve the life of that child. So in this one, it was just a fetus with a chest mass, and here we're just doing a thoracotomy. You can imagine there's continued fetal echocardiography all the way through to see what's going on. This fetus has a big mass in the chest. We could take the mass out of the chest, and just in a very systematic fashion, again, all this done with the child under complete general anesthesia. Most of the anesthesia have been received from the mother, but just some supplemental anesthesia given to the fetus as well. And this one, the mass is being brought out. But once the mass is out and dissected, you have full access to the chest cavity, full access to the abdomen. Really, anything you need to do can potentially be done in the fetus under the appropriate physiologic conditions, using the placenta as the fetus's lifeline to do all that needs to be done. And so here, this one just has this big mass that we were able to get out. It was a big tumor in the chest. We just resected that large cystic malformation that was causing fetal hydrops in this case. It hadn't responded to steroids and needed to be resected. So here the mass has been resected. It's not unusual for these babies at times during the resection for them to go bradycardic and need some cardiac massage. The good thing with the fetus is the heart is so small, you need just one finger for cardiac compressions. And so here's the mass being removed, and you can see we'll be able to go in a little bit and do some chest compressions, some cardiac massage, just direct cardiac massage. And even if you need to give fluid, we're monitoring the heart directly on echocardiogram. We're monitoring the chest completely. Quick cardiac massage there. We can inject directly into the right atrium, directly into the superior vena cava. Excellent access to whatever you need to do in the fetus at this point. And once all that's done, and the baby's in good place, you can volume resuscitate again, giving some fluid into the umbilical cord, and then just close up the chest, put the fetus back in the womb, close up the uterus, and allow the pregnancy to continue. So fetal surgery is here, it's there, it's an opportunity that's there, it's something that could potentially be applied to select cases of conjoined twins. Like everything else with fetal surgery, you don't want to do anything you can do safely after birth by increasing the risk doing it in the fetus, but we know there are conditions where conjoined twins don't make it to term, where we could hopefully have done something before birth, and I think these are the ones that could be amenable to fetal surgery. And I'm kind of running out of time, so I'll quickly summarize. So again, rare complex cases like conjoined twins can be separated with extensive planning. It's important to have all the relevant experts, comprehensive understanding of the embryology, multimodal imaging techniques are important, and of course simulation is extremely valuable for these conditions. Again, I thank you for the time, thank you for the opportunity of the podium, and we'll take questions at the end.
Thank you, Professor. A really insightful and another interesting talk. If I may invite the second speaker up now, Dr. Louis Schiepers, who's going to talk about conjoined twins, the surgical separation may be the easy bit. Dr. Louis is an investigator and paediatric anesthesiologist from BC Children's Hospital Research Institute, Canada.
Good afternoon, everyone. Thank you for attending this lovely conference, and thank you for the committee for organizing it and for inviting us. It's really fantastic to be part of this inaugural event. I'm going to just present, if I can get the next slide. I've got no conflicts other than to say thank you for all the speakers that have gone before me and have basically given an overview of everything, so that whatever I say today is just a reiteration, and if I leave something else, at least they've said it already. I'm going to explore an interesting case that we've recently had at our institution. We have a population of about 4 or 5 million in our province, and in the last 18 years, we've had 4 sets of conjoined twins. One was unfortunately stillborn. One set died at about 4 days of age because of incompatible heart separation. One twin, I'll show a picture of it just now. They're 18 years old last month. They were not separated. They were craniopagus twins. And then one twin that I'm going to talk about on this lecture that we just separated about 7 months ago. And then I'm just going to analyze some of the ethical considerations that we had to go through in our decision to separate those 2 twins. So here's the background for this particular case. It was a 35-year-old mother, and we knew antenatally that she had conjoined twins, and that one of them was a double outlet right ventricle with a tetralogy type of anatomy. And we tried to get her to a term, but she went into early labor. And despite the usual treatment of magnesium and steroids and antibiotics and trying to slow things down, she had an emergency C-section for fetal distress. And these 2 twins were born with Embryology conjoining, weighing in at about 2.6 kilograms together, and at 29 weeks plus 6 days. So they started off life quite behind the 8 ball. It didn't take too long of resuscitation to show that they needed some intubation, so they were both intubated in the delivery room. The whole team was there, anesthesia was there, neonatology was there, general surgery, ENT, and after the intubation they sort of settled down. They went to the nursery, and 4 days later they were both extubated. This was our multidisciplinary meetings. We came up with a timeline that we wanted to expose these twins to. You will see here that we were only planning on investigations at about 3 months of age, with tissue expanders to follow 2 months later, separation 2 months after that, and then repairing the cardiac defect in twin B, we called twin B Lucy, and twin A we called Veronica. And that was about eight months after birth. So that was our timeline. But unfortunately, Lucy didn't read the timeline schedule. She didn't read the textbooks, and she decided to carry on with her life. And I'll show you now what happened. But this is one of our early 3T CT reconstructions. Fortunately for us, there was just a liver bridge. Sorry, there was just a liver bridge over here that they wanted to separate. The bowels were separate. On the other 3 CT images, we could see 2 gallbladders, so that was a good sign, and the hearts were separate. This was just the antenatal MRI, where you could see the liver bridge here. This is one fetus here, transverse, and this is the other fetus here in the sort of vertical plane. So, as I said, Lucy didn't read the textbook, and she started desaturating, developing TET spells type of symptoms. And at that time, the echo showed that there was quite a high gradient RVOT obstruction. It was quite dynamic in that it started at the ventricular outflow tract already and went all the way to the valvular level. This is our echo, just a one-time cine. You could see on this side, this is the, without the color Doppler. You can't really see the tract, the outflow tract there at all, but you can see that the turbulence starts quite early and then obviously go all the way to the valvular level. She progressed in her symptoms, and by day 22, she had to be urgently intubated because persistent desaturations and bradycardias. And at that time, things settled down for a little bit. We found that we had to intubate her when she was on the right side of her twin, but that didn't really relieve the hemodynamic obstruction. Then we had to flip her back to the left side of being the twin, and then that settled down, and she had some decent pulmonary blood flow, and the saturations at least went up into the high 80s. But now we had a problem. You know, we couldn't really progress to surgery because we weren't really prepared. The plastic surgeons really wanted to expand with some tissue expanders because they were worried that they couldn't primarily close the abdomens. The primary general surgeon who was looking after these babies happened to be on holiday for these few days. The operating room was on a Friday, and so it was completely unprepared for having an emergency surgery for 2 teams. On top of this, because these twins ticked all the boxes for a very high mortality rate, and we've been through all of these statistics before already in this conference, you can see that even if you take these numbers, they're all a little bit old, they were all sort of in the late 80s, early 2000s, but even as you can see there, the papers from fairly recently, 2019 to 2023, they still quote these statistics. And we just heard from Esther in the previous session that the mortality from the emergency separations in the Philippines was something like 88%. So we could tell the mother here that, you know, about 50% of the time we might lose one, and if you have 2 babies, 50% of the time makes 100% for at least one of them. So nobody really wanted to do the surgery. Fortunately, as simple omphalophagus, maybe the mortality rates could be a bit lower, but that doesn't negate the fact that they were extremely premature, very low weight, and that we were going to do this as an emergency level. On top of that, when we tried to work through this in our decision-making, we tried to follow the 4 principles of the ethics sort of decision-making tree. The one principle being beneficence, that you try and do good to your patients, you try and give them a positive experience with your treatment. You obviously try and do non-maleficence, you try and not damage or not harm them. You try and be just and fair, so you can give the same treatment to every patient that you come across, and that you try and preserve the autonomy of the patient. Now, if you take these 4 principles and apply them to conjoined twins, you will always benefit one and harm the other or shortchange the other one. In the case of conjoined twins, you will never be able to preserve their autonomy because they obviously cannot make those decisions, and you'll have to refer to the parents and use them to make the decisions. When you look at these 4 principles and you apply them to conjoined twins, there are a few classes that you can roughly group the twins into. I just called them category A, B, C, and D. Category A being on the far extreme of the one side where you can't really separate the twins because either both will die when you try and separate them, or both will be so disabled that the surgery will not really be called a success. Or maybe you expect that they will both pass away within 6 months because of their comorbidities. Or if you decide that if you separate them, they may not do so well, but if you don't separate them, they could live quite healthy and fulfilling lives. And this has been brought out by lots of literatures that adult twins that are not separated don't mind their status. They don't really want to get separated at that point in time. And then Kalberg, who's a professor of philosophy at St. Louis University in the States, he doesn't think that that is such a bad state to be in. He believes that the twins attain the goods of conjoinment, which means that they become sort of interactive with each other, they use each other for companionship, they use each other for emotional, intellectual development, much like a marriage between two people, so it's not such a bad state to be in. This is our first set of twins that we had 18 years ago at our institution. It's Krista and Tatiana Hogan. Some of you might have read about them. They've just turned 18 last month, but they were craniopagus twins that we were not able to separate, and they're doing very well at the moment. Their brains overlap so much that one of them can control the leg of the other person, and the other twin can control the hand of the other person. So they're quite unique. On the other side of the spectrum, the easy sort of separation would be the uncomplicated omphalopagus type of separations. These generally you plan to separate after a few months of stabilizations. And obviously this approach assumes that surgery is what you want to do. Everybody thinks that surgery is the gold standard. But there is a group of philosophers or ethicists that believe that if you do the surgery without the consent of the twins, that you are actually sort of stepping over the boundaries of the ethics, and that you should really wait until the twins can actually give their own opinion as to whether they want to be separated or not. Now, in between these two groups, A and D are the more difficult ones. Group B is slightly easier to deal with, I think, because it's gone through a lot of research already, a lot of discussions. This is where one twin is reasonably good. You expect them to survive if you do separate them, but the other twin is dependent on the first twin, and you do not expect this twin to survive or do well on their own. And this is where the ethics conundrum comes in, and that if you do separate them, you're basically sacrificing the second twin. And from a medical point of view, we can understand that we're doing good for the one twin, but from an ethicist point of view or a layman's point of view, you're still sacrificing or you're killing that second twin because they're going to be harmed or they're not going to be viable. The most famous case here, obviously, is the Mary and Jody case from the UK, the Maltese twins, and they went through the courts, and the court struggled with this, right? There was a court case, then the court case had to go to the appeal case, and there were 3 judges involved with the appeal, and each judge had to do like a separate verdict to try and come to the same conclusion for the 3 of them. But they didn't just say, oh, I think we should separate these twins. They had to come up with lots of reasons and arguments to try and substantiate their final decision. And these sort of conclusions that they used have been used over and over again in some of these cases. The first one they used was the effect of the doctrine of double effect, where you do good for the one, but you know as a consequence of doing that good for the one person, you're going to be harming a second person. This principle is actually developed by Thomas Aquinas, I think in the 1600s, as a way to try and substantiate self-defense when you actually harm somebody during that process. So it's actually a very old principle. But that was not good enough on its own. The court had to come up with other reasons, and they used a child welfare reason where the court had to make the child's welfare paramount importance. And when the parents didn't want to separate these twins, but the doctors wanted to separate them, the court had to decide what is good in the best interest of the one twin, and they had to take that decision away from the parents. And the final principle they used was the one of the unjust aggressor, where Mary was taking the circulation from Jody, not because she wanted to, it just happened to be there. So she was the aggressor, but she wasn't intending to be the aggressor. That's why they called it the unjust aggressor. Now, they had to do all these reasonings because they had to protect the doctors. The doctors didn't want to go and separate these twins and then be accused of killing the one. They had to protect the parents so that the parents didn't feel that their decision or their lack of consent ended up killing one of their babies. So at least that decision was taken out of their hands. And they also had to protect future people that were doing the same sort of surgery so that they would not be accused of manslaughter if they had to sacrifice twin B. So there's all a very complicated process, but at least this one has gone through the courts. The final category, category C, is the most difficult one, because this is one where both will survive, maybe one better than the other one, And how do you decide which one is going to be better? How do you decide where you draw the line for who gets the kidney, who gets the better liver part? These are all decisions that the team has to make on a daily basis. And if you follow those 4 principles of the ethics that I talked about, beneficence, justice, and autonomy, you cannot consistently apply them to both the twins and come out ahead. So this is a particular problem. Fortunately, sometimes it's more easy than others to decide, but this is something that each separation team has to move through. I come back to Kohlberg in 2018 with his a paper on amputations or separations in conjoined twins. He doesn't like this option. He calls this amputation of one part of the one twin, even though you transplant it to the other twin. He feels that that should not be a decision that the caregiver should make. He believes that the twins should grow up to make that own decision and take it out of the physician's hands. Not that you agree with that, but that at least gives you a little counterbalance. In the end, we decided that we had to try and do something for these twins. There were 8 people that had to decide. 7 of them wanted to either wait or see what happens. They didn't really want to go ahead straight away because of all the mortality associated with the emergency surgery. But there was one juror, one standout, was cardiac anesthesia. They didn't really want to wait. Cardiac anesthesia obviously has lots of experience dealing with hepatologies, and they were feeling that the right ventricular outflow tract obstruction was not going to improve, that the maximum medical therapy has been reached, the patient has been intubated, is on 100% oxygen, has all sort of medications, and that is not going to help anybody. And if you allow that situation to progress, then both twins might end up having mortalities. Fortunately, the mother, I don't know, there's mother intuition, but she came around first and thinking, well, the best chance of for both babies would be to go ahead with the surgery. And once the mother said, okay, let's do the surgery, the dad said, okay, no problem, whatever the boss says, I'll go follow. And then after that, the surgeons kind of went with what the parents wanted. We intubated at 11 o'clock in the morning. We had multidisciplinary meetings until about 3 that afternoon with all sorts of teams. The final decision at 3 o'clock on the Friday was made to go to the operating room. We got there at about 5:30. We finally separated just after 11. The abdomen was started to be closed at about 20 to midnight, just 40 minutes after midnight. And we finally got to the PICU at about 1:30. And fortunately, to Plastic's delight, they were able to close the abdomen primarily, and the use of the tissue expanders never factored into this final separation surgery. And I know during the conference we've had some controversies about tissue expansion, whether we should use them or not, but fortunately in this case, we did not need them. Lucy did not do very well in the ICU. She continued to be desaturated and having issues with her RVOT obstruction, and she went back to the cath lab about 2 hours later for an RVOT stent. You can see the initial picture of the cath lab. There was the very narrow pulmonary outflow tract right there. There's just a pinhole there, but fortunately that was enough to keep her alive for these few hours until they could put the stent in. There's the stent, and then when you do an echo, you could see now that there's a lot more flow that's completely open. There's a little bit of turbulence, but much less compared to the previous one I showed you. She did pretty well, but had to come back for a second stent about 4 weeks later, at the end of May. They dilated the first stent and then extended it by putting in a second stent in. She was extubated shortly after that and went home June 14th, so what's that, 3 months after the separation surgery. And then she came back on October 18th to have the final repair done. Let me go back. And she left the hospital about 4 days after the actual final repair. Veronica, the other twin, she's the stronger twin, generally without the congenital heart defect. She was extubated on March 29th, and she went home about the same time as her sister, but she just needed to be there for feeding and bundling. She didn't really need to be in the hospital. It was just a matter of convenience. she could have gone home in the early of April already. All right, just to conclude, I present a little interesting case and then the conundrums that you face with making these decisions. If you remember the 4 principles of the ethics or the decision-making tree and try and apply that to these situations, you will always come up with conundrums that you have to try and deal with. You will never be able to get 100% answers to each of these 4 principles. And when you try and especially apply them to the last scenario, category C, where the one twin is a little bit weaker than the other one, maybe one is more dominant in terms of the organ systems, you will find that it's a very difficult decision to make, but you will make the best one that you possibly can, trying to do good for both of your kids that you have in front of you. Thank you very much.
Thank you, Dr. Shiba. Very insightful talk. I would like to invite next Prof. Sylvia Chivano, Professor of Biomedical Engineering, UCL Institute of Cardiovascular Science, Great Ormond Street Hospital. And he's going to talk about surgical planning and 3D reconstruction. Oh,
Thank you very much. And good afternoon. First of all, I would like to thank all the organizing committee and the Kingdom of Saudi Arabia for really leading on this important initiative. I work with a small team of engineers, computer scientists, and physicists at University College London, but actually our center is embedded within Great Ormond Street Hospital. So we, as a group of technicians, share the same spaces as the clinical care team. And this is key for the type of work that we do. Indeed, we use a lot of the clinical data and the patient information, and we try to integrate these with the engineering technologies that have been developed for all sorts of other engineering fields, from automotive to structural engineering, electronics, with the idea of trying to bridge the gap between the clinical needs, the patient care, the diseases, and all these amazing tools that have been developed nowadays out there, in order to really support the decision system and the clinical care team. What are these engineering technologies? Well, pretty much everything that we do starts with the imaging, and we spend a lot of time processing this information to try and recreate models, reconstructions of the patient-specific anatomies. And you can see some examples there of congenital heart disease. We have an in-house facility to be able to then translate these reconstruction and models into physical objects made out of plastic that are replicas of the patient's anatomies, made with sort of different materials, different colors. We can use transparency, compliant material, and also integrate all these different technologies. We have developed in the last few years virtual reality applications that has really been done in collaborations with the clinical care team, with the surgeons, to make sure that all the tools that we integrated are actually helpful in their decision process, in the planning of the surgeries, in studying the cases, and they answer and respond to their requests. We, in case of complex cases, spend time working on patient-specific computer simulations. We replicate the case of the specific patient on a computer where we can test all sorts of different procedures, treatment solutions. We can have structural analysis for understanding the interactions between devices and the specific implantation site. We can look at the hemodynamics during surgeries and after surgeries, for example, in congenital heart disease. And we can integrate these type of simulations to really disentangle the information between the structure and the function. And the idea is very much to try and answer specific questions for each individual child and case. So, for example, what is the best device? What is the best solution for that specific disease? Is it possible to do the intervention or not? And These type of technologies are incredibly important where we're trying to bring new solutions into clinical practice. And finally, we have developed through the use of this computational model a way to look into not only patient-specific solution, but also populations, disease-specific ideas. So how we code this with any kind of parameter to describe a population with the mean and standard deviation, we can now do it also with the three-dimensional information, so the anatomical information represented in the population with the mean and the variations around this mean. And this has been instrumental in the development of machine learning tool for congenital disease. You probably know that AI requires loads of data, big data, to be able to actually work efficiently. And this is an issue in congenital because cases are usually pretty rare, sometimes unique. But with the use of these technologies, we're being able to integrate the information from several different sources and reduce the amount of time that we take to do the computations. So now we can have an answer directly from the images of the patients to the functional outcome in pretty much real time. And nowadays, with kind of really small errors. So this is improving by the day with the access of more and more data. Finally, we work as engineers, so we have access to technologies in the lab in terms of testing, mechanical testing, hydraulic testing, and electronic testing. And these engineering technologies are used pretty much in 4 different areas. We look at design and engineering, teaching and education, communications with both the patients and the general public, and of course, as a clinical tool. Design engineering is very much focused on new treatments, new solutions, and in particular devices. In terms of teaching and education, we leverage the technologies, the virtual reality, the 3D printing, to try and democratize access to expertise, to unique resources like specimen libraries, to access and allow as many people as possible to have access to these solutions. We use the technologies also to improve the informations between the expert, the communications between the expert and the non-expert. And these type of technologies are really appealing for the children and the young patient. So it's very important to try and engage, especially the young people, when they need to transition to the adult world from the pediatric care. In terms of the clinical use, I will use the opportunity to present our experience with conjoined twins. And this started quite recently, 6 years ago, when with the first case of a craniopagus set that was already discussed this morning by Professor Gilani. So we really spent a lot of time looking at the images. We sat down with our colleagues in neuroradiology to fully understand all the different structures and try and represent this one in a easy, comprehensible way. We integrated 4D flow advanced cardiovascular imaging to try and better understand the venous hemodynamics in the conjoined structures. And of course, we input all these informations in virtual reality. Maybe if there is the volume, otherwise, this just shows the use of the virtual reality tool by the surgeons during the planning phase of the surgery for the communications between the different teams and to be able for the surgeon himself to manipulate these complex three-dimensional informations at any point in time. We then use several 3D printing models to practice the different approaches in terms of the surgery. And as shown also before with the kind of mock simulations in theater for all the people involved during the surgery to be exactly on the same page and to improve the communication process. I'll share now this case of a set of Omphalopagus twins that was separated a couple of years ago. Mainly to show, again, the use of the virtual reality tool for the planning purpose in these complex conditions where you can really appreciate the relationship between all the different structures, but also as a tool to, again, improve the communications. This is the morning of the surgery. The room is just next to the operating theater where the twins were being put to sleep, and the entire team, from the general surgeons to the anesthesiologists to the urologists, plastic surgery, orthopedics, all the different specialties, but also the junior doctors, the colleagues, the visitors, really had the opportunities to fully appreciate and understand the plan without any need for interpretation of the complex images data, because the information was all there and shared with everybody. The final point related to virtual reality that I would like to make is just showing this case that was, again, already presented, that was referred for consultation to our team at Great Ormond Street Hospital, and the set of twin was actually in Brazil. This was at the beginning of 2022, and the UK was just coming out of the third national lockdown, so traveling was actually quite difficult. So we used the virtual reality platform to have both teams from Great Ormond Street Hospital and from Brazil joining in the same virtual room and discussing the planning and deciding on how to proceed for the case without need for traveling.
Prof. Givano, 2 minutes. 2 minutes.
Yes, just quickly. What is going to happen in the future is very much that we need to become better at predicting the outcomes for these twins. We can do the planning, we need to be better at predicting outcomes, but this very much relies on data. So we started doing this to understand how the skin expansion can work. We use the information from previous patients to try and understand how much is the growth from the moment when we get the information in terms of imaging and 10 months later when the surgery actually happens. We use this information to calculate the amount of skin that is potentially available at the time of surgery, and by producing these virtual surgical results, we can also understand how much is the skin that we need actually to be able to have a successful result. And we analyze the same type of data of the previous things that we have available to understand how much we can produce with the use of the saline in the tissue expanders. And this allows us to have good predictions of the amount of expanders and the amount of saline required to have enough skin to proceed with the surgery. The final approach was done through the use of craniofacial spring distractors, where we have quite a good experience at Great Ormond Street Hospital in terms of both the clinical side, where we use them commonly in craniofacial disorders, but also in terms of modeling. So this is the current set of twins. These are the images after the first surgery. We have done a lot of simulations in terms of understanding the best position for the springs to be able to produce as much skin as possible during the surgeries before tissue expanders got in. And this is actually the result after the spring has been inserted. Finally, if we can produce better prediction models, we just need to make sure that these are actually brought accurately into the surgical theater. And we can use augmented reality and mixed reality to achieve this. So we can use simple tools with these QR codes to project the patient's virtual model onto the real child's head in theater. And by simple machine learning tools, we can accurately predict what will be the outcomes in terms of the volume, for example. And these can be delivered accurately using then potentially good implants design and 3D printed cutting guides that will allow the full process from the planning into translating into the real actual surgical plan and surgery in theater. And with this one, I would just like to thank all the people that made this possible, and thanks once again this initiative that will really push forward the boundaries for this set of twins. Thank you.
Do we have time for the last speaker? You have time? Okay, so last but not least, I'm going to introduce Dr. Sheikha Mtawa. She's a fellow pediatric cardiology in King Abdulaziz Cardiac Center, and she's going to talk about abstract and prediction of separation feasibility in conjoined twins with cardiovascular anomalies based on junction type and mode. Dr. Sheikha.
Good evening, all. I would like to express my gratitude for giving me this opportunity to present our study with the title of Prediction of Separation Feasibility in Conjoined Twin with Cardiovascular Anomalies Based on Junction Type and Mode. First of all, I would like to highlight on the previous study which was mentioned by my colleagues earlier in this conference with the title of Evaluation of Cardiovascular Anomalies in Conjoined Twins, a single center experience from King Abdulaziz Cardiac Center. This study was conducted by my esteemed colleagues with whom I have had the privilege to work with them. This study was published in European Heart Journal in 2014. It is a retrospective study from 1997 to 2014, including 42 sets of conjoined twins with different level of body or organ fusion. So the oldest study was basically looked at the cardiovascular anomalies in conjoined twins, while the aim of our study is to predict the ability to separate the conjoined twin depending on the conjunction mode and type. So the presence of complex cardiovascular anomalies is a critical factor that may prevent the separation of conjoined twins. So the question behind our study was, can we predict the complexity of cardiovascular anomalies based on the junction type and mode, thus predicting the feasibility of separation from cardiac point of view? And before going through the abstract, there are a few points regarding the classification of conjoined twin that I want to clarify. So the conjoined twin are classified into three big major groups depending on the conjunction mode, meaning the site of conjunction. Is it ventral from the front, dorsal from the back, or variable when one of the conjoined twins is underdeveloped and attached to the other conjoined twins? So then, these types or these junction mode are subdivided into types, which are the junction types. Ventral conjunction mode has 4 types, starting with thoracovagus when the conjoined twins are joined through the chest. Omphalovagus through the abdomen, esophagus through the pelvis, and paravagus from the side. While dorsal has 2 subtypes, the vagovagus from the sacrum and craniovagus from the skull. And this photo demonstrates the parasitic type of conjoined twins. So this is the retrospective descriptive study, analyzed 78 sets of conjoined twins evaluated at King Abdulaziz Medical City for assessment and possible separation between 1997 and 2024. The presence of major cardiovascular anomalies was assessed based on predefined criteria. Data were categorized by conjoined twin type and junction mode, and statistical methods were applied to identify pattern and predictor of major cardiovascular anomalies. So the cardiovascular anomalies are subdivided into 2 groups, major cardiovascular anomalies and minor cardiovascular anomalies. Each has many diagnoses. Like in major cardiovascular anomalies, when both hearts of the conjoined twin are fused either through the atrium or the ventricle, or one or both of the heart of the conjoined twins is maldeveloped or underdeveloped, or there is an abnormal connection. Minor cardiovascular abnormalities, we mean fused heart at pericardial level and any lesion other than the major cardiovascular anomalies. And when there is a fusion at the pericardial level, this will not defer the separation of the conjoined twins. Now we'll go through the results of our research. So this map highlights the countries of origin of the conjoined twin and, that has been accepted into the Saudi conjoined twin program, and to include 26 different countries from east to west, north to south. The majority of the conjoined twins are from the kingdom, followed by Yemen, Egypt, Sudan, and Iraq. 61% of the conjoined twins were female. And now, by saying the junction mode, we mean the side of conjunction. So 81% of the conjoined twins were ventrally joined, and 14% of them were conjoined or joined from the dorsum, and 5% are variable. And trichoomphalobagus is the most common type of junction type, followed by equally by thracobagus, omphalobagus, and ischiobagus. All of them are ventral conjunction mode. Going to cardiovascular classification, the cardiovascular anomalies were classified depending on a predefined criteria that was studied in the previous paper. So we have three types, type 1, type 2, and type 3. Type 1, when both hearts of the conjoined twins are normal. Type 2, when both of the conjoined twins' hearts are abnormal. Type 3, when one of the conjoined heart is normal and the other one is abnormal. And then these types are again subdivided. So type 2, we have 2A, when the heart of the conjoined twin has both of them has minor cardiovascular anomalies. 2B, when both of them has major cardiovascular anomaly. 2C, when one of them has minor and the other one has major. Then type 3, there are two subtypes, 3A and 3B. So 3A, when one of them has minor cardiovascular anomalies and the other one is normal. And 3B, when one of them has major cardiovascular anomalies and one of them is normal. So the area of interest in our study are the three types, 2B, 2C, and 3B, when one of them at least has major cardiovascular anomalies.
Dr. Sheikha, 1 minute.
Okay. 32 sets of conjoined twins had major cardiovascular anomalies, and 18 sets of them were both when both of them has major cardiovascular anomalies. So this table showed the cardiovascular anomalies in relation to junction mode. We found that all the conjoined twins who has major cardiovascular anomaly, almost 100% of them has ventral conjunction, while no one with major cardiovascular anomalies has dorsal connection. And looking to the data the other way around, 50% of ventrally joined twins has major cardiovascular anomalies, while dorsal is 0%. And from this slide, we can see that the thoracobagus type of conjunction has 100%, or 100% of them has the major cardiovascular anomalies. So in conclusion, the study demonstrated that the type of conjoined twins and their junction mode can predict the possibility of presence of complex cardiovascular anomaly on conjoined twins. These findings can significantly impact clinical practice by minimizing the need for extensive imaging in cases with a poor prognosis, thereby optimizing resources allocation and patient management. So let's take an example and imagine if they refer to you as trichoomphalobagus conjoined twins. So by now we know that 60% of them, they will have cardiovascular anomalies. So you took this patient, you did for him transthoracic echo, and you found that they have complex heart with diffused heart at atrial and ventricular level. And by that time, you know that the separation is not possible. So no advanced transfer process, no extensive imaging and labs, and no pre-op team and no MDT. So we save our efforts. So our recommendation from this study is starting the workup with detailed echocardiogram in conjoined twins with ventral junction mode can lead to significant reduction in manpower requirements and associated costs. If the referring institution lacks the experience in performing comprehensive echocardiogram in conjoined twins, deploying one of our specialized personnel to the site rather than initiating the transfers protocol would still fulfill the objectives of our study. So this is me having opportunity in doing echo in one of the conjoined twin set. And I advise you to go through this chapter in the Manual of Pediatric Cardiac Care book. It's talking about echocardiographic evaluation of cardiovascular anomalies in conjoined twins. And thank you.
Thank you. Thank you, Dr. Sheikha. I think this will bring our scientific session to the end. It's been an interesting 2 days and very insightful. And I think there is no time for questions just because we are kind of tight in time. If there's any questions for the presenters, you can just speak with them individually. So thank you.
We would like to proceed with honoring our guests for this session. Mr. Chris Rockenbach, Dr. Hisham Al-Sha'lan, Professor Oluyinka Olutoye, Dr. Louis Skeepers, Professor Sylvia Schiavano, Dr. Sheikh Al-Mutawa. Ladies and gentlemen, it is my privilege to share with you on behalf of His Excellency, Advisor at the Saudi Royal Court, Supervisor General of Case Relief, and the head of the Saudi Conjoined Twins Program, Dr. Abdullah Rabi'a, the final recommendations from the International Conference on Conjoined Twins. This historic event brought together global medical experts, humanitarian organizations, government officials, and families of conjoined twins to exchange knowledge, share success stories, and explore opportunities for international collaboration in the care and treatment of conjoined twins. The conference also coincided with the inaugural United Nations World Conjoined Twins Day, which will now be observed annually on the 24th of November to share awareness, advocate for the rights of conjoined twins, and highlight the importance of global support for these children and their families. We would also like to highlight the incredible achievements of the Saudi Conjoined Twins Program, which has evaluated 143 cases from 26 countries and successfully separated 61 pairs of twins. This program continues to serve as a global model for medical excellence and humanitarian care. Now, I am pleased to share the final 8 recommendations from this important conference. Conjoined Twins conferences should be convened every 3 to 5 years to ensure continuous dialogue and foster international cooperation. Ongoing research should be conducted that will enhance the diagnosis, treatment, and prevention of the occurrence of conjoined twins. A global website to be established to provide accessible information for families and medical professionals. A dedicated international fund should be established to support the care and follow-up of conjoined twins. Collaborative funding efforts should be made to ensure the sustainability of initiatives, including the engagement of philanthropic foundations, organizations, corporate partners, and private donors. There should be international attention focused on this rare anomaly through a global partnership between international organizations and other interested parties to raise awareness and identify, if possible, ways to prevent such phenomena. We urge all international organizations, scientists, and media forums to advocate for the rights of conjoined twins, to help focus attention on them, to devise the best methods to manage cases, and to educate the public on the topic. Finally, to commemorate World Conjoined Twins Day each 24th of November, globally, through events, campaigns, and educational initiatives. Ladies and gentlemen, as we conclude this historic event, we would like to express our deepest gratitude to all of you, our speakers, moderators, participants, and guests for your dedication and insights over these 2 days. This conference marks the beginning of a stronger, more collaborative global effort to support conjoined twins and their families. Let us leave here inspired, ready to make a difference, and committed to advancing care, advocacy, and innovation in this field. Thank you and safe travels home. We look forward to seeing you at future conferences.
Let me just add His Excellency Dr. Abdullah Rabi'a's thanks and appreciations for your presence at this meeting. He was not feeling well and that's why he left. Special thanks to His Excellency the Minister of Health of Pakistan, also the Cameroonian International Red Cross representative, and all the guests and delegates who are with us until this time. And we hope to see you inshallah in the next conference. Thank you very much.